Good evening. Welcome to all the speakers and participants on behalf of the Narayana Health Oncology Group and the Collegium especially. And thanks to the Collegium for encouraging these kind of continued medical education events. And today we are focusing on robotic surgery in head and neck. The panel, the speakers, they need no introduction, and we're really fortunate to have a stellar crowd with us here today. Before we begin, I think I would hand over the virtual podium to our first speaker for the day, Dr. Paleri. Sir is a professor of head and neck surgery, a well-known robotic surgeon at the Royal Marsden NHS Foundation Trust, London, and he has recently been elected as the president-elect of the BAHNO. So congratulations to you, sir, for that. And he'll be speaking first on selecting the ideal candidate for TORS, the current evidence. Over to you, sir.
Thank you, Harsh, for asking me to speak and organizing this. I'm going to quickly share my screen, folks, and then can you see my screen and can you hear me well?
Yes, sir. Well seen, well heard.
Thank you, Harsh. It's a pleasure and a delight to join you. Happy Sunday, all, whichever part of the world you are joining us from. It's the last day of winter here in England, and it's slowly beginning to brighten up. And I hope wherever you are, you've had a safe journey so far through the COVID pandemic, and you and your family are all well. On that note, this was an interesting topic to put together, Harsh. I think you must have had some insider knowledge that they'd closed Orator 2, and it's made it all the more challenging to bring in that information together into this talk. So hopefully we'll make some headway, and in the next 30 minutes, I'll show you how you can go about within your MDT, your multidisciplinary team, go about selecting the ideal candidate for TORS. So the way I thought we'll play this is use some case-based vignettes. I'll look at the evidence base, we'll look at cancer control, we'll look at some quality of life measures, and I'll spend some time giving you a research update and commenting on where we are from a research perspective for this particular topic. So who, in my eyes, would qualify as an ideal candidate for TORS? Patients for whom surgery alone will serve as a single curative modality would be just ideal for TORS. You know, they come in, they have the operation, even if you do a concurrent neck at the same time, recovery is rapid. Within 10 days to 2 weeks, in my experience, patients are back to almost normal levels of swallow, unless it's a supraglottic tumor, which takes longer than that, but tongue-based, and tonsil resections, they get back to pretty good swallow outcomes at 2 weeks. And from then on, the way is only up because patients improve. And when I see my patients who have had single modality therapy, at 6 months' time, apart from the external scar for a neck dissection, there is little else to be seen. They're pretty much back to good functioning. So in those instances, I think TORS would be, these patients would be an ideal candidate for transoral robotic surgery. The other group would be patients in whom surgery can inform adjuvant radiation, because if you're in a position where you can be precise about the radiation you're offering the patient, you can offer risk stratified radiation therapy. And if the radiation therapy that is risk stratified and precise can offer functional benefits to the patient, those patients would also be an ideal candidates for TORS. And lastly, if one can avoid transmandibular approaches, that would be ideal from a management setting, because transcervical, transmandibular approach tends to disrupt a lot of anatomy, leading to significant morbidity. And these are broadly the categories of candidates who would be ideal for transoral surgery in the setting. I'm not going to deliberate and go into depth about the 8 T's that can impair access to the tumor and therefore may prevent it from doing transoral surgery. These are well articulated in the literature, and I think we should have a higher level of discussion here as opposed to drilling down on entities such as trismus and other entities that can impair your access and therefore limit offering patients dose. Fundamental to offering transoral surgery within your MDT is within your setting is a multidisciplinary team. Do you have your oncology colleagues on board with this? Do they fully understand what the margins imply in your particular patient? Do you have your oncologists who can subscribe to this criteria for single modality therapy in early stage cancers, to offering patients risk stratified radiation therapy? If this is not built within your MDT team, and if you work within a team or a center where patients will inevitably get standard of care radiation therapy in this setting, be it adjuvant or curative doses, then it begs the question, why should you even offer minimally invasive surgery? So these are entities to be sorted out within your team before you embark upon offering patients transoral surgery. So as I said, well, we'll use some cases to illustrate these issues, and at the end of each case, I'll look at the data available and discuss ways forward. So this is a 72-year-old male. He's a retired vascular surgeon. He presents with non-specific throat symptoms. Performance status is excellent. We see something funny at the back of the tongue. We get an MRI done. MRI shows a 10mm tongue-based lesion with nothing to see in the neck. We biopsy that. We can confirm it's squamous cell cancer. It's P16 positive. Access is decent. We take him to theater, and we perform transoral robotic tongue-based hemiglossectomy. We always take pictures, and this is for our own benefit, the MDT's benefit, and also for the pathologist, more importantly, because this gets sent away to pathologists, and the team will then look at this systematically. We annotate it to hell and back. We try and invert the specimen so the mucosal side faces down to avoid flattening out your lovely margins on the resection specimen, and the pathology comes back within 7 to 10 days or so. So in this setting, where a patient with an early stage cancer has had transoral robotic resection, these patients, I believe, are ideally suited for this particular modality alone. Let's look at this man. So his pathology has come back showing he's got a 20mm tumor, the top end of T1. It is 3mm from his closest margin. Remaining margins are pretty decent. We've done his neck dissection. Neck shows N0 node, N0 status. So he's a PN0, PT1 with a minimum margin of 3mm. So that's his pathology on the right-hand side. On the left-hand side, you can see the different margin specifications used in different studies. Some I've chosen the larger ones, and in different prospective trials too. So you can see the significant variation in the way people have chosen what are their marginal commitments in the setting. 2 trials are closed for multiple reasons, not because they did badly. That's the MD Anderson 1, which is row 5, and ADEPT, which is Bruce Hoey's study. So given a 3mm margin in this setting, you have to question yourself, what would your MDT recommend? Let me get on my margin soapbox for just a minute. So if you subscribe to the 5mm margin cutoff, don't forget that this is based on really weak evidence. It's based on an old study published in 1978 with 62 patients in it, which is a convenience cohort from a 1,000 plus patient cohort. And these 62 patients were assessed for recurrence, and a convenience cutoff of 5mm was used. And a subsequent survey of the American Head Neck Society members showed that people believe in the 5 millimeter, and therefore this is considered to be an appropriate margin. But the bottom line is no uniform criteria exist to define clear surgical margins. And more importantly, many studies systematically done with a better approach to analysis, and not a convenience cohort, but a consecutive cohort, have shown that the truth lies perhaps between 1 and 2 millimeters. We won't go into that. That's mainly oral cavity literature. But if you look at the oropharynx literature, let's look at this particular paper. Small cohort, 30 patients. The margin chosen was 2 millimeters. So UPenn, which is who have understandably, arguably published the first papers on transoral robotic surgery, have used 2 millimeters as a cutoff. And one of the first papers clearly indicated a very high local control with a robust long-term follow-up too. And this is the basis for using the same 2 millimeter cutoff for their AVOID trial published by UPenn. So you have good data showing that a less than 5 millimeter margin might suffice in this setting. Let's go a step further and see what the nearby team in Pittsburgh did. So this is the ECOG 3311 trial. Many of you would have come across this, submitted and presented at ASCO just a year gone by. And in this particular study, if you look at the top orange box, the low risk box, 3 millimeters was chosen as a cutoff. So when patients had achieved 3 millimeter plus margins, and you had N0, PN0 or PN1 node with no extranodal extension, these patients received no further adjuvant therapy. And this trial clearly recruited lots of patients, but the most relevant for this particular patient we're looking at now is Arm A, which had 37 patients in it. And if you look at the data set coming through from this particular study, you have 94% of patients enjoying a progression-free survival at 2 years. So good data, a nice prospective cohort, and this cohort also marries up with the data published so far from other centers prospectively. Plenty of data on this. And as I said earlier, I won't show you the quality of life data for this particular group, but as I said earlier, this group does really well once you offer surgery and you're happy with the margins. Recovery is very quick, functional recovery is quick, quality of life is excellent, and patients even go back to work within a month of their treatment completing. So it's fair to say that in this particular group, this would suffice. Just prior to the ECOG 3311, a large national cancer database analysis was performed by Dr. Duvvuri. A very nice piece of work, which led to assessment of 1,700 or so patients. But in that patient group, if you look at the low risk once again are the patients who have more than 3 millimeter margins with N0 and N1 disease with no extranodal extension. And the N1 is the old style TNM7, it's not the TNM8. So you can see that whether patients had surgery or surgery plus radiation therapy or surgery plus chemoradiation therapy, they had pretty decent 4-year overall survival with no significant difference across the groups, with a good median follow-up too. So there is a fair amount of information, and I suspect if you had a 3 millimeter margin, this would fly well with the Pittsburgh multidisciplinary team. They would say, yeah, this is a T1 stage, they have no neck disease, we're happy with this. But if you work in a team which really believes in the 5 millimeter margin, I can tell you this would not be an ideal candidate for you. So the point I'm trying to drive at is your ideal candidate selection is not just driven by the T stage, by the N stage, by the M stage. It's driven partly by the MDT as well. What does your multidisciplinary team believe in? As what's the ideal margin? When should you treat? When should you not treat? So that's the point you need to take away from this first case. You can have an early stage cancer, but you need to know what your MDT ethos is in this particular setting. Let's look at case 2. Younger guy, 56-year-old businessman. He comes to us with a 29 millimeter tonsil mass. So it's T2, clearly T2. Nothing to find in the neck. And again, it's a P16 positive squamous cell cancer. I'm going to focus on P16 because I know we have a later speaker coming in to talk about P16 negative and HPV negative tumors. So the bulk of this talk will focus on this. And of course, we'll touch upon other things too. So it's a P16 positive tumor. And with a 29 millimeter mass, it is very likely that this patient will have occult mets. Again, you need to think back. What will your MDT recommend? Is this patient ideal for a single modality? Will he get away with single modality and possibly risk stratified radiation therapy, or will he need more? So I discuss him at my MDT, and I say, next shows nothing. It may be microscopic spread, at the most N1. I'll do a TOES on him, achieve a clear margin, and then bring him to MDT. He undergoes a nice operation. He does well. We send him away, send the specimen away to pathology, as always, annotate it properly, goes to pathology. They look at it very clearly. And 3 weeks later, he's doing really well. He's got a nice neck clearance. PN0, 44 nodes, nothing in there at all. Bit of shoulder soreness after neck dissection, as you would expect in this setting, but a good nodal harvest. Again, on the left-hand side, for reminder, I've given the list of studies showing what are the margins they use. This is his pathology. So I'm going to milk out a few scenarios from this man. This is not his true pathology, but let's say it comes back as a poorly differentiated squamous cell cancer. It is 2.5 millimeters from the deep margin and 5 millimeters away from the others. Let's say, hypothetically, neck dissection is negative. With a 2.5 millimeter margin, what would your MDT do? Remember, the ECOG 3311 and Dr. Duvvuri's large NCDB dataset indicated 3 millimeters as cutoff. This is 2.5 millimeter. You can ask your pathologist to go and add the other 0.5 millimeter along. We got other papers recommending 2 millimeters. The question is, what would your MDT in this setting want you to do? What would they recommend? Let's look at the data once again. So this patient would drop into the intermediate risk. Okay, if we go back to the NCDB analysis, it looks like in the intermediate risk group, whether patients have surgery or surgery plus radiation or surgery plus CRT, the overall survival remains the same. I understand the intermediate risk is not driven by margins alone, it's driven by the nodal status too, but it's a mix of data here. But clearly it shows that these patients will do well with surgery alone, but we don't have high-level data in this, and clearly it's observational data set. There is another slight nuance to this, okay? If it is a tongue-based tumor, like in the first case, you can get your 3 millimeter pretty consistently. If it is, on the other hand, a tonsil tumor, it is a bit awkward because the superior constrictive thickness is just 1.92 millimeters. You're never going to get 3 millimeters with the best will in the world. So it's a slightly nuanced argument. So with that being the case, if you look at tonsil tumors, you're going to find it difficult to achieve your 3 millimeter margin. So when we looked at this particular problem in the Newcastle MDT, where I was for a while, we looked at 47 patients who had TOES alone for tonsil cancers. Good median follow-up, 43 months. Look at a local control. DSS is pretty respectable. There's no question. It's very similar to Dr. Duvvuri's data on the NCDB and the ECOG 3311 data. But when we performed a receiver operating characteristic curve assessment to define a binary distinction for a margin, the cutoff we got was 1 millimeter. So I've got my own local data in my MDT to show my colleagues we might get away with something smaller than 3 millimeters, which is 1.1. And my patient now has a 2.5 millimeter margin. And this nuance is taken into consideration in the best of trial, the EORTC 1420 trial, where Christian Simon, the chief investigator, he has clearly specified in non-tonsil tumors, we need 3 millimeters across the board. In a tonsil tumor, Christian very clearly says it's R0 or R1. R0 is where there is no tumor on the other side of the constrictor. R1 is where there is tumor. So the nuance is taken into consideration for tonsil tumors in a prospective randomized controlled trial. So that is something you must consider. Again, this is something your MDT would buy into in the absence of higher level evidence. We don't know, but that is something, that's a discussion you need to have. So within my MDT, for a 2.5 millimeter margin, in this particular situation, I think I would get away without offering the patient adjuvant radiation therapy. As an update, 1420 had an original accrual goal of 160. It's dropped to 112 after further analysis, and this is doing reasonably well. Not the best, but doing reasonably well. We need 6 more cases this year from the UK to make it fly. Let's milk out scenario 2 for the same man, the businessman who had a 29mm tumor. We've taken his cancer out. Let's look at this pathology. Again, he's got a 2.5mm deep margin, which is less than the 3mm that EORTC 3311 needs and most of the prospective trials would need. But you have additional issues here. We have a non-cohesive pattern. We have a focus of vascular invasion. We have perineural invasion. What do you do now? This gets slightly sticky. This won't fly terribly well at most MDTs. I know these are soft indicators of tumor aggressiveness. We have no good, hard, robust data for this, but you got to look at this from a perspective of your oncologist and your MDT looking at the pathology thinking, you got something going on here which isn't right. It's much more than a conventional SEC with showing certain features. What's the data here? So again, back to 3311, this falls squarely in the intermediate group. Not only have we got close margins here, we have PNI, we have LVI, we have no nodes and falls into intermediate group. So I think very few MDTs would get away without recommending radiation for this particular patient for this in scenario 2 is my take on the matter. Whether you use 60 gray as adjuvant dose or 50 gray is again a decision to be made locally, but let's look at the data on this. The results of ECOG 3311 indicate that, so arm B is a group that had 50 grays in it. Arm C is the group that had 60 grays in it, intermediate group, and look at the 2 years progression-free survival. Pretty decent, very comparable to arm A2. Again, I have to emphasize, this is not a phase 3 trial. This is not a phase 3 trial you can hang your hat on. This is a phase 2 trial. And the conclusion we can robustly draw from this is that transoral surgery plus low dose radiation is worthy of further study in a phase 3 setting, okay? Because it met the specified pre-trial a priori criteria. Because it met the criteria, we can now take it to the next step, which is to examine this in a phase 3 trial. We have no data to indicate this will now show that this is definitely the way forward, and a head-to-head comparison between transoral surgery plus risk-stratified low-dose radiation needs to be done against radiation therapy alone to generate the higher level phase 3 data that our patients deserve. So you can't, at the drop of a hat, change practice based on this. You can have a discussion within your working team, your multidisciplinary team, to look at your local results and potentially examine circumstances for a change. But a phase 2 trial alone doesn't allow you to change this. Again, in a top-notch team, A-level team like the TMH and the ACTREC, would you change that based on a phase 2 trial? I suspect no, there'll be significant resistance to doing that. But what it does allow you is to offer more, to generate more confidence in a lower dose and to show that these patients are worthy of further investigation. Let's go to scenario 3. This is now a P16 negative tumor. You have the same size tumor, again no nodes, but then your margin has gone down. This is what happened to this chap. I have a 0.7 millimeter margin from the deeper aspect, and 3 and more on the other sides. So what really happened was I went to the path lab, looked at where I went wrong in terms of not getting his adequate margin, because I assessed him to hell and back. I knew this was a resectable tumor, would get a decent 1+ millimeter margin, but this is what happened. So when they sliced it, you can see where the ink is. The ink is where the tumor stops with the margin. A piece of muscle had sheared off from that particular site. And this muscle you can see here is quite a large chunk of muscle. This is what I think came off from here, but that is a non-winning argument. The slide shows that there is a 0.7 millimeter gap between the tumor and the resection margin. And on that basis, most MDTs would recommend adjuvant treatment. And given that it's less than a millimeter, this is as good as a positive margin. In most MDTs, patients would receive adjuvant concurrent chemoradiation therapy. So this is the difficulty we have in this setting. So we need good protocol-driven care for patients, and a scenario, an ecosystem where you need to apply these protocols to patients irrespective of what, based on what the surgical pathology shows. Can you contest that? Can you contest the 0.7 millimeter margin? Is there any data on this? Yes, there is. This is a Liverpool data set, 264 patients, and they published a mature data set now. You can see the 5-year overall survival, 3-year survival, 3-year OS is very similar to the ECOG 3311 and the other published data sets. This is 5 years overall survival. Patients from Liverpool, there's a high history of smoking and deprivation. Clearly, the OS will be lower. But look at the disease-specific survival, very much comparable to others. Within this cohort of 264 patients, 197, nearly 200, had the so-called R0 high-risk margins, less than a millimeter, or they had E&E. Yet these patients did not receive chemoradiation therapy because of local, these are local practices. They received just radiation therapy alone, and the outcome is very much comparable to other data sets where patients have received CRT. So clearly within an MDT, it's worked and they've shown data. They're going to carry on doing the same thing despite a less than millimeter margin. But Liverpool's now doing the Pathos trial, which has a different inclusion criteria. We'll come to that in a minute. So this data will fly within the Liverpool MDT, outside perhaps the Pathos trial. Will it fly elsewhere? It may not. So you need to look at within your own environment and see if this particular thing will work. Is there any more comeback against the sub-millimeter argument? There is, because we are now giving concurrent chemoradiation for these patients on the basis of the RTOG 9501 and the other randomized trial across in Europe, which is the 22931. But if you drill down and look at the HPV positive, P16 positive patients within these two trials, the number you're getting is 13 within RTOG and 4 in EORTC. You can derive those numbers from trials that took place in the same era, which have then gone on to assess the HPV positive oropharynx patients in it. So we are largely extrapolating data from 2 large RCTs into the HPV positive population, but that's level 1 evidence, and we are hamstrung by what we have, and it's our job to generate high level evidence if we need to come back against this. But as things stand now, we find it quite difficult in most MDTs to de-escalate. And we've learned a lesson. We've got our fingers burnt. Recall the cetuximab phase 2 trial that Shanti Marud led, that led to RTOG 1016 and the de-escalate trial, looking at cetuximab, head-to-head comparison, cisplatin versus cetuximab. What that showed is we can't de-escalate. We de-escalate. Both trials had to be stopped, despite having a fairly large non-inferiority margin. The RTOG 1016 had a 1.45 in non-inferiority margin. That is quite generous for an oncological trial. And clearly, having had our fingers burnt, we should be very, very careful before de-escalating on the basis of phase 2 data. So I'm going to finish that section of the talk. So the point is, it's easy to say, we got TOS, we got to de-escalate. These are low-risk patients, we can get away with it. No, we haven't got the higher level data. So we need to very carefully look at our practice, very carefully look at our own outcomes, and methodically and incrementally apply these within MDTs. So it works in certain MDTs, may not work in certain MDTs. It's a matter of how you perceive the data, but there is not an easy one answer fits all for the question you've asked, Harsh, which is, who is the ideal candidate? A lot depends on what your MDT practice is. I'm going to spend a few more minutes talking about the commentary on recent data and recent trials. This is Orator 1, which is a phase 2 trial. Again, I think these trials need careful interpretation. So I'm going to really go slow. I apologize if I'm taking more time, but let's go slow and try and work this through systematically. This is a phase 2 trial. It's a phase 2 trial where we've randomized patients into transoral robotic surgery and neck dissection versus radiotherapy and chemotherapy in this setting. And patients are followed up. The clear margin definition is more than 2 millimeter for tonsil tumors. They recruited 68 patients, 34 per group were randomized, and the outcome showed that the mean MD Anderson score at 1 year was advantageous for the radiation arm compared to the transoral robotic surgery plus chemoradiation arm, with a p-value that was significant. And there was 1 death caused by bleeding after TOEs. But essentially, we have an issue here. If you look very carefully at the table, the primary outcome measure is a total MDADI, and a clinically meaningful decline is 10 basis points. Do we have the 10 basis points here? We don't, because on that basis, on the 10 basis points difference, the p-value is 0.25, indicating that this is a negative phase 2 trial. And a negative phase 2 trial doesn't necessarily add much data to what we're doing. The implications are, if you're pursuing something, you don't have to change practice. A negative phase 2 trial tells us that the trial can be conducted. It's shown successful recruitment, but in the absence of a positive signal, it's quite difficult to pursue this in the setting. So Orator 2 was designed, and to understand Orator 2, we need to take a step back and look at the NRG HN002 trial. So this is a trial that randomized patients with HPV positive, low risk oropharyngeal cancer into 2 arms. Arm 1 is chemotherapy with radiation therapy, but it's a dose de-intensified radiation therapy regime. Look at that. That's the treatment regime, 60 gray. Your conventional treatment is 66 to 70 gray. So this, the NRG002 looked at lower dose of radiation therapy in this setting with chemotherapy and compared that with an accelerated radiotherapy dose, same dose, but delivered in 5 weeks. And being a phase 2 trial, you have to compare the arms to a preset criterion, just like what he called 3311 did. The preset criterion here is a 2-year performance progression-free survival of 91%. So arm 1, which is the low dose radiation with chemotherapy, met the criterion and rejected the null hypothesis. However, the accelerated radiation therapy regime without chemotherapy did not meet the PFS estimate, and therefore it failed. So it shows that arm 1 is now worthy of further investigation in further settings. So Orator 2 is Orator 2's radiation arm is NRG HN02's radiation arm. There's no change there. This is the lower dose radiation therapy with chemotherapy for selected patients, and some of the doses in low risk areas will be different to 60 gray. On the other arm, it's TOEs, transoral surgery of whatever kind with neck dissection and adjuvant radiation based on the pathological risk factors. So again here, this is not a head-to-head comparison of these 2 modalities necessarily. So based on Orator 1, which had a 94% overall survival rate, the sample size calculation was done. They pre-specified that neither of these arms would achieve an overall survival 84% or less. So giving themselves a 10% leeway, the investigators hypothesized that based on Orator 1, neither of these de-intensified arms would achieve an overall survival of less than 85%. So with that being the case, they went ahead, did this piece of work. And like most things these days, you get information on Twitter. So I saw this on Twitter first, and then a kind soul just dropped me a nice photograph of Anthony Nichols presenting this, the reasons why the trial was halted, picture taken from bed, as you can see. I won't name name where the picture came from. Thank you very much, moderator, madam. So that's so the trial was halted. This came through just 2 days ago. So we had one spinal abscess, which is why which led to mortality, and the other one was a fatal hemorrhage on post-op day 5 after a tongue-based resection. So we can only speculate now. So there are many speculations here. So I'm going to speculate on the reasons why the trial was stopped, and then we'll look at the implications of this. So the data monitoring committee in the trial protocol said that if the rate of grade 5 toxicity was more than 5% in either arm, they would stop it. That means you need 3.5 patients, or at least 3 patients for this to stop. We had just 2 mortalities. So I don't quite get it why this was the case. So this is very clearly specified in the protocol. The rate of grade 5 toxicity related to treatment is more than 5%. We haven't reached that. I don't have information. There must be some more additional information. There must be good reason why this was done. The other issue that I had with the surgical protocol of rated 2 is that the surgical resection, they mandated that surgical resection be carried out with at least 1 centimeter margin. I've been doing toes for a while. I don't use 1 centimeter margin for these patients. It is difficult. If you took a 1 centimeter margin for a conventional T2 tongue base, you're way across the midline for every single patient you operate on. So clearly, there might be reasons in why patients bled and had a spinal abscess. I have no information on that. But these are things which have halted this trial. What are the implications here for us? The implications are, if you look at arm 2, that is same as ECOG 3311 arms B and C. So you could say that we already have some information about arm 2 from what ECOG has reported. We have information on arm 1 from NRG HN002 trial. So it looks like in many ways, this is a nicely constructed phase 2 comparison. In many ways, these questions have realistically been answered by other studies, and it's good to replicate data. And to me, it doesn't necessarily stop my practice of toes. Rated 2, while it's disheartening for all of us, is really disappointing. We've all wanted to see the results of this. It doesn't necessarily, you need to look at your information, look at your data. It doesn't necessarily halt practice, because here's more data on this. This is my Newcastle cohort, 120 patients. I got 3 deaths related to concurrent comorbidity, not because of surgery. Gallstone peritonitis, another one, cardiac failure from pre-existing heart disease. So these are the mortalities I'm seeing, not from actual surgical intervention per se. Again, back to Terry Jones' data, 2 deaths from bleeding from a 264 cohort. So we're not seeing this in the real world. In very carefully collected data from prospective cohorts. So again, you need to go back to MDT and reflect on Orator 2 data once it's published and see what changes need to be made, can be made to reflect your practice. Pathos, again, a large UK-led trial. Current accrual goal is 1,082 patients. I spoke to Terry Jones yesterday. They have a stoppage rule for more than 5% drift or non-inferiority. Their DMC hasn't said anything about stopping. So to me, as things stand now, if you're performing transoral surgery, transoral robotic surgery, Orator is a bit of a shock to us all, but I can't define a good reason for you to stop doing what you're doing on the basis of the Orator 2 trial. Do I have time or have I overshot?
So I think maybe just 1 or 2 more minutes to wrap up, because
Okay.
So sorry for that. We were absolutely enthralled, but we need to just be.
Oh no, totally, yeah. 2 minutes is perfect. So case 3 is fairly straightforward. This is, to my practice, is straightforward, and there's something you need to take away as a message today. Radio recurrent setting, radiation, and then the cancer recurs, be it at an early stage, at a later stage. We've been doing this for a while now, and I'm convinced that TOES is a good modality for radio-recurrent tumors. This is a patient with a tonsil and tongue-based recurrence, a small tumor. removed completely, sent away, and these patients do well. It's a bit of fun we have in theatre by dropping into formalin and doing ultrasound in theatre. And you can see that's a tumor, the hypoechoic region, and that's a cuff you get around it. And it seems to be a decent way to look at the margins you get. So we looked at this data very carefully. John Hardman's my PhD fellow, and he's put a lot of work into this. It's a systematic review of 161 patients, and you can see the 2-year overall survival, 20% less than what you would get in the primary setting in a carefully selected cohort. But I'm pleased to say there's more activity on the way. The RECAT study has really done well. We have 16 global centers, 2 from India. We have data as an individual patient data meta-analysis on 257 patients, 50 awaited. I've seen some of the early analysis, and I'm reasonably impressed. We're going to present this at the EHNS very soon, but this is interesting data, and this could potentially change practice. So there's a bit of a taster for you. But I can stop by saying that if you have a T1, T2 recurrent tumor in this setting, TOES is an acceptable modality based on all the data we have seen so far. So in conclusion, it's continues to be a valid modality for oropharyngeal cancer treatment. You need very clear multidisciplinary consensus for gray cases. What's your margin? It's 2.5, it's 2.7, it's 1.9. What do I do there? We need clear consensus in this. And that's the way forward. That's the only way you can collect robust data. Monitor outcomes very carefully. There's a clear role, I think, in recurrent cancer and in diagnostics. And I would always say more research is needed at the end of the day, because it really brings in more data. It's been a hard time during COVID. I lost my Tash, and Harsh, there's you in those good times. It's great. Thanks for the invite, and it's a pleasure to be here. I'll hang around the panel, which I look forward to. Thank you.
Extremely thank you, sir. That was a wonderful talk. A lot of great insights, and the most important message I think which you drove home was, what does your MDT believe in? What is your ideal candidate? So probably you need to sit down with your tumor board and obviously look at evidence and then decide and select your patients. Just a quick question, maybe a minute to respond to this, sir. Is there any significance of depth of invasion in oropharyngeal cancers with respect to prognosis and also for defining a Juvenile treatment? A minute on.
I haven't come across any, and it seems to be mainly driven by margins. Yeah, I haven't come across any for oropharyngeal cancer.
Okay. Thank you so much, sir. That was exciting and interesting as always. We'll go on to the next talk of the day. I would like to invite our next speaker, Dr. K K Thankappan, sir. He's a professor of head neck surgery and robotic surgery at the Amrita Institute of Medical Sciences at Kochi. And sir would be speaking on robotic thyroid surgeries, climbing the learning curve. Dr. Thankappan, over to you, sir.
Hi, good afternoon and good morning. Let me just share my screen. Am I seen and audible? Hello?
Yes, sir, you're audible, yes, and you're seen as well, sir.
Absolutely. Right. Thank you, Harsh and Sourav ji. I'm going to talk on how to climb the learning curve as a beginner. Some of you might have heard this presentation, especially the faculty. Bear with me. So, climbing the learning curve in robotic thyroidectomy. When we heard about robotic thyroidectomy, our initial thoughts were, there are few patients in our daily practice who request for a keyhole thyroid surgery. And most of them are young females. And there are few surgeons in the city offering endoscopic thyroidectomy. And endoscopic and robotic thyroidectomy is done in many centers in South Korea and few centers in America. This was our initial thoughts. And our initial confusions and questions were whether to do it. Will it benefit the patients? Is it not invasive? And can it be done for malignancies? So with that, let me define remote access thyroidectomy. It's when incision is placed in a site remote from the neck, permitting thyroidectomy without a scar in the anterior neck. The amount of surgical invasiveness is usually more in case of these approaches. There are multitude of approaches now described, like a minimally invasive anterior cervical, that is MEVAT approach, and many remote access like chest or breast, carbon dioxide assisted, endoscopic, robotic, and of late we are hearing too much about the the transoral approaches. The pros about the robotic thyroidectomy is its visualization, the dexterity of surgery, the precision, and the surgeon ergonomics. The established complication rates are supposedly similar, with the recurrent laryngeal injury rate, hypocalcemia rate, and hematoma is rare. And oncologically, efficacy is proven from many studies, especially from South Korea. Cosmetic outcomes are obviously better because the scar is hidden. But the limitations are the cost and that there is no tactile feedback, and being a rigid endoscopy, there could be visual obstruction and inter-instrumental collision. The literature says the learning curve is about 35 to 40 cases, and it is less than endoscopic, where they say it is about 55 to 60 cases. So the training, we thought about getting trained in robotic thyroidectomy. The training involves having open thyroidectomy skills, which we all have, and then about basic robotic skills training. And then we should go for a robotic thyroidectomy training, which can be, again, human cadaver specimen training, observership, and then hands-on training. And then we should have somebody to guide us through the initial few surgeries, and that's called the proctorship. So the basic robotic skill training and the robotic thyroidectomy training we had in Korea with Dr. Ko and Dr. Tae. Many of you might have heard these names. And as proctorship, these two surgeons came to our OT, and they stood by our side when we did our first few thyroidectomy surgeries. Credentialing has to be done by individual institutions. The SAGES paper says the institutions have to grant privileges to the surgeon. The basic principle is that the surgeon must have the judgment and training to safely complete the surgery as planned, as well as have the capability of immediately proceeding to an alternative way when circumstances indicate. It's always important to talk about the teamwork in this instance. It's better that two surgeons from an institution get trained together and team up in surgeries. We have found that it has helped us. Me and Dr. Iyer went for the training, and we do surgeries together. Next point is about choosing the robot. In our country, we have two options mainly, the XI and SI. We don't have the lavishness of having the SP robot in India. So SI is an old model where 4-quadrant surgery is possible with redocking, but redocking may not be needed in an XI model. In SI, it is a 12 millimeter endoscope, but we have 8 millimeter endoscope in the XI, which can be kept in any of the arms. And 5 millimeter instruments were available for SI. I don't think it is right now available even for SI. And for XI, we just have 8 millimeter instruments, and a harmonic instrument is not available for XI. So this is the robot which we have in our OT, the XI model, surgical robot, Da Vinci. And it has a patient card which goes into the patient, and a vision card, and a separate surgeon console. Regarding the instruments, there are skin flap retractors like skin hooks, Army Navy retractors, Langenbach retractors, and one specially made self-retaining LNC bio robotic retractor, which we got from Korea. And other instruments for gross dissection like monopolar cautery, Yankor suction, the metal ones, and vessel clips. Patient selection is the most important point. It depends on the patient factors like body habitus, racial differences, skin suppleness, pathology, whether it is thyroiditis or cancer, and of course the size of the whole thyroid and the size of the thyroid nodule. At this instance, I make a statement that there is a fraction of patients in our practice who may want to avoid a visible scar, and they will benefit from such approaches. While open thyroidectomy continues to be appropriate for most thyroid cancers, robotic approaches may be feasible on select patients with thyroid cancer patients with high cosmetic expectations, and the emphasis should be on selecting patients. You have to remember that neck dissection is possible with robotic approaches. So an ideal patient would be a small or average sized with BMI less than 30 young patients with concerns of neck scarring or history of keloid or hypertrophic scar, an indeterminate thyroid lesion less than 4 cm in diameter, or confirmed papillary thyroid carcinoma less than 3 cm in diameter, multinodular goiters with smaller nodules, and total thyroid volume less than 40 ml. Relative contraindications would be T2 well-differentiated thyroid cancer, thyroid nodule more than 5 cm, larger goiters, Graves' disease, Hashimoto's thyroiditis, and morbid obesity. Absolute contraindications would be a thyroid cancer with gross evidence of involvement or invasion of the surrounding structures, previous neck surgery or irradiation, and a substernal or retrosternal goiter. The patients has to be counseled and consented. Select the patients who are coming with a request for such type of procedures. Disclose that the procedure is novel and potentially unknown risks and benefits are there. And if it is a surgeon's first time, you have to disclose that, and you can tell about your training. And when adequate numbers and outcomes are available, those can be provided. Now, which approach to choose? When we started, we had two options in front of us, the retroauricular and transaxillary approaches. Now, people are also thinking about transoral approaches. So how did we go about? So this is a slide which I borrowed from Dr. Tay, comparing and contrasting the axillary approach and the post-auricular approach. I'm not going to the details of it, but we chose robotic retroauricular or post-auricular thyroidectomy. It's a remote access approach, gasless open approach where incision is hidden, and it's a modified facelift approach, initially described by Dr. Terrace and popularized by Dr. Ko from South Korea. What were the advantages we saw in the post-auricular approach versus transaxillary? The anatomy and the vector of dissection is familiar to a head and neck or an ENT surgeon. The brachial plexus is not at risk, and the area of dissection or the length of dissection is shorter compared to the transaxillary approach. Now, I always show these slides in my presentation. How do we go about while you are on your learning curve? How do you select cases? Select young, non-obese, thin neck patients who are requesting for robotic surgery and the nodule is less than 3 cm, benign or malignant. You can select even malignant nodules even if the nodules are small, but without any clinical or radiological nodes. Neck dissection may not be possible for a beginner. And total thyroidectomy, if you have to plan a total thyroidectomy if suspecting malignancy, that is Bethesda 5 or 6. Why? Because a completion thyroidectomy may not be possible for a beginner with the robot. And you should always get a consent for a bilateral approach. So Amrita experience of the first 21 cases, I have to admit that the last 1 year, maybe due to COVID or so, we have not done a single case, but this is our experience of the 21 cases. I posted few cases next week, but this is the experience for the initial 21 cases. 4 hemithyroidectomy, of which 1 was a completion thyroidectomy, 15 total thyroidectomy, okay, 15 total thyroidectomy bilateral approach, 2 total thyroidectomy with the central compartment neck dissection, and 1 total thyroidectomy via the unilateral approach. So our initial 15 cases were nodules less than 3 cm, no significant nodes. We made sure that there were no nodes on the ultrasonogram, either central or lateral. We included malignancies and mostly total thyroidectomies, and all were done by a bilateral approach. That means we went in through the one side to take out half and went to the opposite side to remove the other approach. But looking back, I would say it is better to have an initial 5 cases like this before this 15 cases, okay, nodules less than 3 centimeter, benign, and where you could do hemithyroidectomy. For some reason, we didn't do this initial 5 cases on the ladder, but we straight away went. But for a beginner, I would suggest it's better to do go this few steps on the ladder first, like the initial 5 cases, nodules less than 3 centimeter, benign, where you could do hemithyroidectomy. And our next 5 cases, that is cases 15 to 20, were we chose size up to 4 centimeter, and 2 cases of total thyroidectomies with the central compartment dissections. We went ahead and did central compartment neck dissection, not the lateral ones, and 1 case of completion thyroidectomy in this 15 to 20 cases. And the problems in our initial cases were technical, like difficulty in docking all the 4 arms into the post-auricular working space, difficulty in superior to inferior orientation. Our usual orientation is from inferior to superior or the lateral, but here in a retro-auricular approach, the orientation is from above downwards. And there is a foreshortened view. And in the initial 2 cases, we had loosening of 2 planes. We went into the thyroid, and there were difficulties for the bedside assistance and complications. 3 cases of temporary hypocalcemia, distortion of specimen, these 2 cases, and 1 case of bilateral vocal cord paresis and hypertrophic scars. Hypertrophic scars is a real problem, especially in females. We say our post-auricular scar is hidden, but in males they present with hypertrophic scar. That's really a problem. That's one thing that needs to be sorted out. And the cost includes initial establishment cost, annual maintenance cost, disposable charges, prolonged anesthesia and operative times, but it could be minimized by cross-subsidizing, meaning that other departments who does for our institution, like our gynec oncology, has completed 600 cases of gynec oncological cases. So some sort of cross-subsidizing can be done so that your patients are not charged so much. And here is our case 21. Okay, that is when we did a total thyroidectomy through 1 post-auricular incision. We started planning to go ahead as a bilateral approach. Yeah, this is a small video. So this is a nerve on the right side. We identified the nerve and we kept it aside. And suddenly we realized that the tumor is adherent to the trachea. So we removed the tumor, and then some part of the tumor was remaining adherent to the trachea. So we had to remove it separately. So that's a trachea. We are shaving off the trachea, and that was removed. And that's when we realized the other lobe is very small. And Dr. Iyer was with me, and we discussed. And anyway, the difficult part is over. Why not try taking out the other lobe through the same side? And we went about it, and we are trying to do the other lobe, which is a smaller normal lobe, from the same side. And superior nerve was seen in this. And suddenly we came across this unexpected complication. Okay, see, that's it. That's a superior pole of the contralateral side bleeding in a spurter. But I could control it, like holding with the Maryland forceps and bipolaring it. But we had a tough time. And we could complete that total thyroidectomy through the unilateral approach. It was the toughest case. We had problem with shaving of the trachea, and we could remove it from the same side. So this is our summary of about 21 cases, or females were 20 and just 1 male, and malignant cases in 16, like Bethesda 5 and 6. Mean size of the nodule was 25 and 40, and operating time is coming down, and the final pathology malignant in 17 and benign in 4. complications I told, unilateral paralysis nil, bilateral paralysis in 1 cases, temporary hypocalcemia in 3, and broad scar or hypertrophic scar were seen in 3 cases. And the PTH, initially we had a few cases of temporary hypocalcemia. We monitored the PTH on the day 1, and finally we have our PTH values have now stabilized at around 25 and 30. So with that part we are okay. And so the total surgery duration has come down drastically, around less than like 120 minutes or so for a total thyroidectomy. And this is a patient. And we have published our experience in 3 papers. And our plan for our next 5 to 10 cases would be to try lateral neck dissections in the node positive cases, have done it in tongue, T1, T2 cases. Challenge would be the level 4 and 5B, and to try more unilateral approach for total thyroidectomies. To conclude, robotic retroauricular approach for thyroidectomy uses a well-hidden incision, not minimally invasive, feasible, safe, cosmetically better, oncologically efficacy, but patient selection is important. Operating time comes down with increasing numbers. Precision surgery may help to reduce hypocalcemia. And this is our ladder, a minimum 35 cases. First 5 cases, benign hemithyroidectomy less than 3 centimeter, malignant total thyroidectomy, bilateral approach less than 3 centimeter for the next 10 cases. Total thyroidectomy is up to 4 centimeter with central neck dissections, bilateral approach for the next 5 cases. And total thyroidectomy is up to 4 centimeter, bilateral approach and lateral neck dissections level 4 and 5 in 10 cases, and finally total thyroidectomies through unilateral approach 5 cases. That would be about 35 cases when you would have climbed your ladder and you would be on the top to do any robotic thyroidectomy through robotic approach. Try not to get distracted by any new approach that comes out every other day till you finish climbing your ladder. Thank you.
So thank you, sir. That was very, very crisp and very well detailed indications and proper case selection. Just a few questions, if I can, 1 or 2 questions from my side. So what about instrumentation near the nerve? Do you feel that with the robotic systems, with the Maryland forceps and the bipolar, do you feel that instrumentation near the recurrent laryngeal nerve is a bit more difficult compared to the normal steel instruments we use in an open thyroid surgery? And also about the use of nerve monitoring in your experience with that.
Yeah, initially you feel that the instruments are really gross, but when you are near the nerve, you don't go use the cautery part. You just when you reach the nerve, you identify it and try to separate it off and keep it away, and then you can use your cautery. Nerve monitoring we don't generally use, but when we saw it in Korea, they generally use it, and that can be helpful definitely if you use it.
Right, sir. And so in the beginning of your talk, you mentioned that you select your initial cases carefully so that there are no neck nodes. Especially we know that the central compartment is difficult to visualize on the ultrasound. Do you recommend using a CT neck for all your initial cases? Would that
for some reason we don't use CT, but we just used ultrasound, and our radiologist is comfortable in giving us a report about the central compartment as well. I understand the difficulties with the ultrasound, but yeah.
Okay. Right, sir. Thank you for that wonderful talk, sir. I don't see any more questions on the question box or on the chat. I guess we'll have more discussion on robotic thyroid, probably with respect to oncological safety, nodal yield during the panel. So we'll probably go to those questions then. Right. Thank you, sir. Thank you. I now have the pleasure of inviting Dr. Umamaheswar, sir, from University of Pittsburgh. So Dr. Duvvuri is the director of Robotic Head Neck Surgery. He, in his own right, is a pioneer in other robotic systems. He has worked a lot on robotic systems other than the Da Vinci. And we had the good opportunity to visit his lab when we were there in Pittsburgh. And his topic today would be robotic surgery. Where are we now and where are we going? And he'll be highlighting on a lot of technical aspects and newer innovations. So Dr. Duvvuri, it's over to you.
Thank you very much, Harsh. I am very grateful for the opportunity. I hope that this is presenting okay. Is this, can you?
Yes, sir. Could you just go to full screen mode?
Yes, hopefully this will go into.
Right.
Is this in full screen mode for you?
Yes, sir.
Okay, perfect, perfect.
Yeah.
Well, actually, let me just, I have a separate, maybe a small technical thing. Maybe this will be. Is this full screen without the additional?
No, we're still able to see your half on the next slide.
Let me just do one thing very quickly. Apologies.
Mr. Kashish, any inputs from your side?
So you can just click on Control and F5, sir, once you share the slides.
Yeah.
Hopefully this is better.
It's perfect.
Okay, perfect. Okay, just small technical. So thank you for bearing with the technical problems, but it's wonderful to see everyone virtually. I'm very disappointed that we're unable to meet in person, but I look forward to return of travel and seeing everyone. Thank you again to the organizers for allowing me to give this small lecture. So the topic here is robotic surgery of today and tomorrow. So we'll go over a little bit of the definitions of what we're calling robotic surgery. I know many of you are already aware. Briefly go over some of the robotic surgery of today, and then we'll talk about some of the future directions and where I think the field is moving. And I'll have to, first of all, bear with me. I'll have to say that I'm going to repeat a little bit of what Vin has already presented in his very comprehensive and elegant lecture, because I think there are some really, really important points that I hope we will be able to sort of rehash. So going over this details, this is what we normally think of for robots. These are industrial robots and robots that are used to build an automobile, building a car. And so these are what we typically think of when we think about true robotics, because these are autonomous and self-functional devices that allow a task to be completed with minimal guidance and instruction once the initial data is input into the system. However, when we think about robotic surgery, I think it's important to sort of redefine this, because clearly we all know that robotic surgery is not autonomous at this juncture. Robotic surgery really at this point in time is microsurgery, because you are doing delicate surgery and small motion surgery, in which a surgeon performs the act by manipulating the hands of the robot. So here we have what one may more appropriately refer to as a master controller system rather than a true autonomous robot. And this has been the standard of art now in pretty much every system that comes out. But I think in the near future, we might see some changes and see some other interesting information. We've all heard about the advantages of robotic surgery that we may think are true in the general sense of robotic surgery, so maybe not specifically for the head and neck space, but when we think about urology or gynecologic surgery, etc., the advantages clearly are shorter hospital stay. There's definitely reduced trauma to the body when you consider laparoscopy versus an open laparotomy procedure. Presumably less anesthesia if one were to perform these surgeries in a more expeditious time frame. There are several bits of data demonstrating that blood loss is in fact reduced in robotic surgery in general, again, when compared to open surgery, taking into account urology and gynecologic procedures. And then there's also the possibility of less postoperative pain. And in fact, current data that is being published from our institution and others suggests that prostatectomies performed robotically, the patients can be discharged without the need for any narcotic medications, and they can be managed purely with paracetamol and other non-narcotic analgesics, which I think is really, really interesting. And of course, this translates to less long-term pain, so post-operative as well as long-term pain, and presumably some of these other benefits, faster recovery and return to daily activities, as Dr. Paleri presented earlier. So now shifting gears and talking about robotic surgery for us, for head and neck surgeons, I think that it's important to recognize that there are two distinct disease patterns now in the context of squamous cell carcinoma of the head and neck. We have the smoking and tobacco and alcohol-related diseases, HPV negative diseases, which are shown on the left side of the screen. And these diseases are characterized by specific genomic mutations, P53, decrease in P16, and various other cytogenetic abnormalities that we think drive the phenotype of this disease. Then on the other hand, we've got HPV-associated or HPV-positive disease, which has a completely different genomic characterization, which is defined really by elevated levels of P16, and of course, inactivation of retinoblastoma protein and P53, which happen in different ways. But we know that these two disease processes, while they are present in all of our practices, have very, very different phenotypes and very different behaviors. And what much of the Western world has been obsessed with, I would say, in the recent past, is this problem of the HPV-positive tumors. And that's why these trials are designed with for HPV-positive cancers: Orator, Pathos, ECOG 3311, ADEPT, the Mayo Clinic 1273. Numerous trials have been designed to address and tackle the problem of HPV-positive tumors. And the reason for that is that in the Western world, HPV-positive oropharyngeal cancers have increased by roughly 200% in the past few years, and the trend continues to increase. In fact, it was said that the number of cases of HPV-positive oropharyngeal cancers is expected to surpass the annual number of cervical cases by 2020. This is a prediction from Anil, who's a wonderful researcher and bioepidemiologist at the National Cancer Institute. He published this in JCO in 2011. Well, it turned out that by 2018, the curves had already crossed. And in fact, oropharyngeal cancer is now the most common virally driven cancer in North America. So that's why we care so much about HPV-positive disease in North America and in Europe. However, and of course, these data are replicated at single center level. So here's our data from UPMC in Pittsburgh showing that the incidence of HPV positive cases, in fact, total new oropharyngeal cancer cases, has increased dramatically over the past 30 years. And now it continues to increase. In fact, I would say that I see on average 2 to 3 oropharyngeal cancer cases for every one HPV negative oral cavity or laryngeal cancer case. So really, this is a large part of our practice. And so here's the data from Anil Chaturvedi, where he sort of predicted this sort of crossing at 2020, but in fact, the cross has already happened. And so you can see that oropharyngeal cancer in men here has overtaken the rate of cervical cancer, and this is much more common now in North America. But along with this, we also recognize that HPV positive cancers are very treatable, and patients that suffer from HPV positive oropharyngeal cancers have a very, very high cure rate. You know, relatively speaking, 90+% is a cure rate that I think most of us would take for any sort of mucosal or solid tumor malignancy. However, with this improved survival rate comes the problem of trying to optimize therapy for these patients to make sure that their survival is good without losing the quality of life that is associated with the treatment of these patients. And in fact, this is where surgery sort of came into play. And here's some initial data from Carol Fakhri, which he published in Cancer Prevention Research in 2015, showing that patients that had been treated with any type of surgery, this wasn't definitive surgery, but any type of surgery, had better survival when compared to those that were treated without surgery, suggesting maybe there was an effect of debulking or cytoreduction on the management of these cancers. So that was, of course, something very interesting and worth considering. So this sort of brought into the forefront this idea that surgery might be important for the management of these patients. So how do we provide surgery for these patients? We all know about this Da Vinci. So this is the current basic technology that we have, whether it's the SI, the XI, or in some sense, the single port as well, is that these are multi-port in general surgeries, meaning that there are multiple arms that are inserted into the body of the patient, either through a laparoscopic type approach for doing abdominal surgery, or transorally for doing robotic surgery of the oropharynx, or through the retroauricular approach, as Dr. Thankappan has shown, for doing thyroid or neck dissection. But ultimately, you're putting multiple arms into the body. Now, the single site, single port surgery is clearly very exciting, and there have been a couple of attempts to do this, and I will talk really briefly about that. But SP, for example, is one such interesting opportunity to explore this idea. Now, again, we know that TORS is very interesting and has been sort of brought to the scene by Greg Weinstein and the group at Penn, which showed very, very good results. This is the very first study on 27 patients with tonsil cancer, and they placed the robot into the mouth of the patient, and then they were able to perform surgery transorally on these patients, and were able to move this forward. So that's really, I think, was a seminal study that really set the stage for us to move this forward. And of course, now we can expose the tumors, we can put this put the robot in and then do surgery. So clearly exposure is a big problem, right? So in order to define where we're going in the future, what we have to do is to define the problems that we face right now. So one of the problems that we face is, number one, if the tumors are easy to expose, then clearly the surgery is delightful and it's a pleasure to do. But what do we do with patients that have hard to expose tumors, and can we tackle those nonetheless? Here, for example, is a picture of a robotic lingual tonsillectomy that was performed for a patient with unknown primary carcinoma. And so this now changes the face of the argument to ask, well, what are the problems that we really need to tackle? What can robotics help us do that we cannot do with other technologies or other techniques? What is robotic surgery uniquely capable of allowing us to do better? And I think we should all ask ourselves these questions as we see new techniques, new technologies, new approaches. I think KK said it very well. Don't get distracted by the new shiny toy and run after this new approach or that approach. Pick something and understand it very well, but also understand what the real problems are for the patient so that we can then tackle them in the most effective way possible. So that's something to consider as well. So again, when we think about that, when we think about, can robotics help us actually solve a problem that we currently do not have an answer to, or that we do not have a good solution for? One of those questions, and I think Ben has already addressed this, is, can TORS be used as a single modality to treat patients with oropharyngeal cancer, to avoid having to give them chemotherapy and radiation therapy or multimodality treatment or systemic therapy in some sense? And so very, very interesting data. Here's just one specific paper that was written by one of my former residents, Garrett Chobe, where we looked at patients that were treated with surgery alone. So these are patients that fell into one of the observation arms, I would say, of some of these prospective trials that you've heard about already from Dr. Paleri. We looked at a cohort of patients who were treated with this, about 30-some patients. We then looked not only at their survival, but more importantly at their quality of life scores. And so what we find is that after surgery, there is in fact a initial dip in the quality of life scores at about 1 month after surgery, but then they recover very quickly after that. But within 3 months, actually, here we surveyed them at 6 months, but within 3 months, they recover back to baseline. And so there are some very, very interesting kinetics, I would say, of the recovery process that these patients are able to have, and they recover their full activity, they recover chewing, swallowing, pain, etc., recover fairly quickly. So surgery in these patients can be used as a single modality therapy with very good quality of life outcomes. So this was some very old data that sort of set the stage for some of these newer trials and newer analyses that we're doing. But I think it's important to remember that some of these older data are in fact kind of meaningful. So again, the big questions that we're asking in the field are, does upfront surgery improve quality of life or oncologic outcome for these patients? Does robotics provide some real significant survival benefit for these patients? And these are all unanswered questions. These are all really big question marks in the field. It's hard to think that robotics would provide a major survival advantage, because when the survival for these patients is already 90+%, it's very difficult to shift that curve. Most of these trials, that's why, are designed as non-inferiority trials. Excuse me. Swallowing. what is the benefit of swallowing and quality of life in these patients? Can we actually improve the swallowing outcome for these patients, and how does it work for these patients, and who are the right patients that may actually benefit from this? Another big question is, of course, does the pathologic staging affect how we treat these patients? Can we make the quality of life or survival, even though it is 90%, somewhat better for those patients who specifically have poor outcomes? And so does pathologic staging help us with that in terms of doing surgery? That's one question. And finally is, what is the cost? Are these new procedures cost effective? Are they too costly? I saw something in the chat about an instrument, I think it was harmonic, for use with the XI robot, which costs 60,000 rupees per use. And so, if something becomes so prohibitively costly, then is it, what's the value? What's the true value for this? And that's a subjective and individual judgment that every surgeon, patient, and society should make, because cost is, of course, determined on the societal implications of it. So that's something very important, and that's worth thinking about. On that note of cost effectiveness, I think there was a very nice analysis done by John D. Almeida, one of our former fellows at Pittsburgh, who's now at the University of Toronto, who did an analysis of robotic surgery and the cost utility of robotic surgery in terms of what the cost would be versus outcome. And what he found is that if you can treat up to 30% of patients with robotic surgery alone and not have to give them chemotherapy or radiation, then the surgical cost becomes worthwhile. It becomes cost effective. Okay, so it's not just cost that we should think about as in the raw dollars, the cost of a new robotic system or a cost of a fancy new instrument, etc. But what is the value that you get for spending that money? If you understand that value, then I think you will actually develop what's called cost utility or cost effectiveness analysis, not just micro cost analysis. Having said that, in order to define these cost utilities, you have to understand what those utilities are. What is the benefit from doing these robotic surgeries? And so to define that benefit, to define that utility, we have to have data. And that's where these trials play such an important role for the future of the field, not just how we treat patients now, which is very important and very worthwhile. And Dr. Paleri has done a wonderful job of describing that. I want to focus a bit more on how would these trials impact our vision of robotics, 10, 20, 15 years down the road. What do we do with them? So again, this is an example. This is the ECOG 3311 prospective trial that was designed to ask the question, how do you treat patients with oropharyngeal cancer with intermediate risk disease? And so I'm just making sure I stay on time. And so with this, you've seen this data. We see that patients who are in arm A, which is the survival arm alone, has a 94% 2-year progression-free survival. These patients are continued to be followed, and we will get 5-year survival, in sometime the next 3 years or so, and then we will hopefully have data to present on that. But you can see that with 2-year progression-free survival, all arms have very good outcome, but arm D had the lowest, despite having the most intensive treatment of surgery, chemotherapy, and radiation. We see that there was a significant outcome. Now, once again, going just to the orator question, the concept of deaths and morbidity in these cases, you can see here, deaths without recurrence, so deaths sort of associated with treatment toxicity. One in arm B, this was a bleeding complication. Okay, 1 patient died here. None in arm C or A. So within all the surgical groups, we had 1 bleeding death in this particular trial. 3 people died without recurrence in arm D, presumably due to toxicity of surgery plus chemo and radiation. And these data are being presented and are actually currently in review, and hopefully will be published in the not too distant future. So at least you can have some idea of why we're talking about these toxicities. So having said that, now that we know what these progression-free survivals are, then we can sort of ask the question, well, if you improve progression-free survival by 2%, you go from 90.5% in this lowest arm D to 93%, let's say. How much would you be willing to spend for that? If there was a new robotic system that costs, let's say, 1 lakh rupees per case extra, but you think that there's a 2% benefit in overall survival, would that be worth it? Would that be worth it to you or the patient? At least if we have these numbers, we can make those analyses, and we can come up with some metrics which can be used to inform the purchase of these tools and so on and so forth. Right now, we sort of do this in a very ad hoc fashion. So I won't belabor this too much, but then as we get access to these new technologies, we start thinking, well, what new things can we do? How cool would it be if we could do a retroauricular thyroidectomy? How cool would it be if we could do a transoral thyroidectomy? How neat would it be to do a retromaxillary pituitary surgery? Here, I am also a fan of playing with these very interesting toys. So here, we've done over 30 or so robotic neck dissections at Pittsburgh over the past 7 years, and we're just publishing our long-term oncologic outcomes on these patients. And it was really, fun and interesting to explore this and to do these sort of robotics. So you can see here, I'm using the SI robot with the harmonic. But again, we have to ask ourselves the question, yes, we can do this, but what is the value with this? And is this really truly valuable and helpful to the patient, or is it less important from this perspective? And so as we think about this, I think about the new wave of surgeries that can be done and what the real problems are. We should think about how we can now tackle those important problems. One of the big problems that we have, I think everybody would agree, in any kind of surgery, whether it's laparoscopic or even to some extent open, but mostly in laparoscopic endoscopic surgery, is that sometimes we don't see vessels before we encounter them because we're tackling the tumors en face, right? In transoral robotic surgery, if you're tackling a tongue-based tumor, you might be looking directly en face at the tumor, making incisions around the mucosa, and then peeling those tumors and looking at the depth of the tumor through tongue-based musculature. So what if you encounter the lingual artery and you have bad lingual artery bleeding? Professor Thankappan showed a very nice picture of tackling the superior pole contralaterally on retroauricular thyroid and having bleeding, profuse bleeding. So if that were to have been even more aggressive or emanated, let's say, from the external carotid vessel while doing a neck dissection, you can imagine it could be a real problem. There are routinely cases of patients having mortalities, not just morbidities, but mortalities from laparoscopic or robotic gynecologic and abdominal and thoracic surgeries from injuries to the vena cava or the aorta or the pulmonary artery. So if you could identify these, could you now avoid this problem? So one of the ways that we have done this in Pittsburgh is to incorporate intraoperative ultrasound while doing the actual operation. And so I think in the future, we're going to be seeing concepts like this where we're doing an operation. So this is a lady who was a former patient of my colleague and mentor, Jean Myers, who had surgery in the past, and radiation chemotherapy. She now has a second primary tumor, which is HPV negative of the tonsillar fossa. She's very thin. She only weighs about 40 kilos. She is, because she's so thin, here you can see the tumor. I was worried that the external carotid vessels would be very close to the tumor because of the prior therapy, radiation chemotherapy. And so as I'm doing the robotic surgery, I was able to use intraoperative ultrasonography to see where the vessel is, to see the depth of invasion of those great vessels to the tumor. Here we can see a small vessel, but not the main external carotid system. So that's great. So we could therefore understand that we could maybe ligate this vessel. So again, now that I know that there's a vessel potentially coming in this area, we see the parapharyngeal fat. Again, you can see some of the constrictor muscles that we're dividing. Here we can try to identify where that vessel might be. Aha, we've encountered it. So instead of having to deal with this hemorrhage and bleeding post hoc, we can identify it. We weren't sure if there were some branches, so we've clipped this structure. We also clipped the main vessel, of course, and then we were able to place the ultrasound probe back, and now you can see these large vessels, which are actually more indicative of the external carotid system, so the true external carotid system. So now we know that those large vessels, which are just lateral to the wound bed, need to be kept in situ kept covered, and we can proceed with surgery. And then we can, of course, use this to detect the margins of the tumor. So I'm not going to belabor this point too much, but suffice it to say that I think that this is one of the waves of future development of this technology. Now, some of you are probably familiar with this device that I helped to design and develop called the Med Robotics Flex Robot. I'm sad to report that I think the company is unfortunately defunct and no longer in business. I'm not sure of the details. I'm sure we can talk offline. But this was a very interesting development in the field where a flexible robotic arm was designed. I designed this to be able to do transoral robotic surgery because I felt that using straight instruments and putting them into the mouth with 8 or 5 millimeter instruments were too cumbersome. It was too clunky. The Da Vinci robot was designed for cardiac, thoracic, and abdominal surgery. It wasn't designed for otolaryngologic or head and neck surgery. So now we took that square peg and put it into a round hole, and we were able to get it to work. But if we could make this work a little bit better, if it could be a little more slim form, we may be able to get better traction from it. And in fact, we were able to. And in fact, here, we were able to use this sort of flex robotic device to perform a retroauricular operation. So this is a lady with a branchial cleft cyst that we were then able to perform a retroauricular incision, elevate the retroauricular flap, expose it just as you would for a thyroidectomy. But instead of performing a thyroidectomy, we were able to remove this benign tumor, this retroauricular cyst. We performed some of the surgery cutaneously with a headlight, and some of it we brought the robot in, and we were able to perform this sort of operation. I'm not going to belabor this. I can share this video with anybody offline, but it was just an example of how this kind of operation could be done. So now moving on to the bigger picture, the concepts here are today we have some mostly multi-port, some single port, in other words, SP technology. We have some concept of mechanical guidance. We have stabilized motion so that there is no tremor. We have many of these wristed instruments. We can do two or three arm surgery. We also do what's called remote surgery in the sense that we're sitting at a console and then operating the patient side cart, this concept of a master controller. However, the technology of the future, technology of tomorrow, is going to leverage the strengths of each of these and move it forward. I think we will be seeing integrated surgical planning where we won't need to be performing intraoperative ultrasound with a handheld. It'll be built into the robotic platform, hopefully. Maybe it won't be ultrasound, maybe it will be iKnife, which uses mass spec to gauge where the margins of the tumor is by using mass spectrometry of the smoke coming from the cautery. Dr. Paleri has championed this technology, phenomenally interesting technology. It might be Raman imaging to look at discrimination of tumor versus normal. It could be something that we haven't even thought of, but I think it will be there. One of the challenges with Da Vinci surgery currently is that we don't have haptic feedback. We don't know what's hard and what's soft. We can't feel tumor or bone. We sort of see it by how the arms move, but we can't really distinguish the margin of the tumor from normal. So I think haptic feedback is something that's going to be very, very important in the very near future. And finally, I think that we're going to be seeing, and we are already seeing, the integration of artificial intelligence, machine learning concepts so that we can take big data and understand where tumors are coming. In fact, my research lab is currently working with a large medical device company to use and develop artificial intelligence and machine learning algorithms to be able to detect the pulsations of vessels in surgery so that you will actually see that vessel pulsing before you encounter it without any exogenous agents, without any imaging, etc. So I think that these are some of the very, very exciting areas that will be coming forward. We're not quite ready yet to show that, but we will be getting there. Along with this, I think we will also see the development of technology that directly integrates into the robotic platforms. I think we'll see better cameras. As we all know, our mobile phones, the cameras of these mobile phones have gotten better exponentially in terms of the speed with which they work, the ability to use low light, the ability to perform small movies, live, if you will, on iPhone. being able to have better optics. We're getting better and better and better. And I think we're going to be seeing that more and more and more. And eventually we'll be moving these towards better imaging systems that can integrate vision, imaging, and navigation. So this is an example, for example, this is the slide from Dr. Go. I'm sorry. I've gone backwards. I'm sorry. Let me see if I can go backwards here. That shows us the development of these various robotic platforms. So this is a courtesy of Dr. Go from Yonsei, who I know most of you know, to show how the technology is developed from the SI to the XI to the single port. But all of these developments have been relatively, I would say, modest in terms of being able to allow a camera to be used in multiple arms, like the XI versus the SI. With the SI, you know, the camera sits only in one arm, so therefore the XI allows for multi-quadrant surgery. The single port, of course, has flexible arms and is able to enter the body cavity through a single point of entry. But at the end of the day, we're still sort of grasping tissue, cutting tissue, sewing tissues back together without significant and true changes in the functionality and true depictions of this technology. So in the very near future, I think we'll be seeing this total integration of surgical care. In fact, remote surgery, simulation, warm-ups, intraoperative navigation, and maybe even molecular imaging, which I think is incredibly exciting. What are some of the platforms that are coming out in the near future? We have the CMR Versius robot. This is very exciting. This is from Cambridge, so Cambridge Medical Robotics, but they've changed their name now to CMR. So this robotic platform uses individual arms that are not controlled by a major boom, if you will. This also allows the surgeon to sit at a console and operate off of a screen, but your head is not buried within the console of the Da Vinci, so you can see what's happening in the room. We all know one of the problems with doing Da Vinci surgery is once your head is in the Da Vinci console, you lose a bit of perception of what is happening in the theater around you. And so this open platform may help to avoid that. And the fact that these arms are portable means that you can use 3 arms if you want for a case, you could use 4 arms for a case. Theoretically, one could use up to 7 arms. You could have 3 arms controlled by one surgeon and 3 arms controlled by another surgeon and a camera. So that might really allow for true multi-port, multi-quadrant surgery. Think of, for example, a minimally invasive esophagectomy, where one surgeon could be operating in the thoracic cavity at the same time that another surgeon is mobilizing the stomach conduit in the abdominal cavity. Fascinating, fantastic, you might say, but maybe this is the wave of the future. And this, of course, is a recent paper. This is a picture published by Asit Arora and JP Janon, who are in London, who have performed some cadaveric studies using the CMR robot in cadaver heads. And I have had the privilege of using the CMR robot in a cadaver model as well. And I find it to be really quite interesting and potentially fascinating for the not too distant future. Now, here's another very interesting company called Active Surgical, which is making this star robot. I'm actually going to turn the volume off because this is a commercial from the company. I don't mean to disclose this as a commercial. I have no real interest in this financially, but this is a concept of using a robot that could be single port, as is shown here, based off of an arm that was developed by the German defense called the DLR project. And now this robot can actually perform automated surgery. It can actually suture and repair a hernia by sensing with imaging the depth of the peritoneal cavity, by imaging the depth of the inguinal ligament, for example, and it can actually perform autonomous suturing. So this is the robot in action. You can see the surgeon has delineated these dots, and this robot is coming in and placing a stitch and moving and actually suturing. And I can tell you that I have actually worked with this company, and I've actually seen this technology in its development. And while it's not quite ready for prime time, it will be coming. So I think there will be a not too distant time when we will actually have true surgical robots that will be able to perform autonomous tasks, not merely tasks in a master-slave type of system. This same company, Active Surgical, is also now developing multispectral imaging and hyperspectral imaging, which will again delineate blood flow in tumors or blood flow in the human body without using any contrast agents. You don't have to give anything. They want to create a technology that will just plug into your standard camera, and then if you flip a switch, you'll be able to see blood flow. So here you can see this is a model of porcine model, I think, or a rat model, and these are kidneys. This is the vena cava. These are the renal vessels, and then the infrarenal vena cava and aorta. And so you can actually see blood flow here without having to give contrast agents. So you can imagine that this might be really useful to delineate perfusion in a flap, to look at the skin panel and on perforators on a microvascular flap. It really is a brave new world. So having said that, I'll conclude here, and I will say that the future is indeed bright. The existing technology, I think, is outstanding in terms of Da Vinci technology. I think that this is true. I liken it to the old computers of the past. I think we can all, those of us that are old enough, can remember the old 386s and the 486s and the Pentiums. We thought that those were amazing machines that were so fantastic. And they did a great job. But now our iPhones, independently, each iPhone probably has more computing power than 1,000 of those old computers, right? We have incredible amounts of power, RAM, etc. And so I think that robotics is in that same phase where the technology is expanding at such a dramatic rate that we are now needing to catch up with it. But most importantly, it should be front and center of our mind that our ultimate goal should be to provide the highest quality of care for our patients. It's not to use the coolest technologies, not to use the newest robot or to perform the transoral thyroidectomy, or as Ashok Shaha likes to joke, the transanal thyroidectomy. The point here is to provide the best care for our patients, which means that as surgeons, we should be very thoughtful of understanding what are the limitations of what we can do now. What is it that I wish that I could do that I cannot do? What are the real challenges, and what is the gap in knowledge that I have to provide better care for my patients? And that might be something very molecular, like understand the genomics of why certain patients fail. It could be something very practical, like I just can't see the exposure on this particular patient, or I wish I had a better retractor, whatever it is. But if we can define those problems, then we can articulate those problems to our colleagues in industry so they can then move this forward. And I will summarize by saying that India is at an incredibly powerful position right now. Most of these robotic companies are coming to India and the South Asian subcontinent in general to do the clinical trials, to refine these tools. The Medtronic robot, the CMR robot, several others, I think even Transenterics, are coming to the subcontinent because there is such a strength of intellectual strength of surgeons and the need of patients to be taken care of, so they can do appropriate trials and really define this. So I think the Indian surgeons have a unique opportunity at this juncture to shape the future, to provide the right comments so that the technologies are developed to what we can all use to improve the quality of our patients, not merely a black car versus a gray car, but really think about what things can be modified. And I would encourage you to ask these companies to provide that information for you. And with that, we can then use those tools and study them prospectively. Prospective studies are so important. I think Dr. Paleri has articulated this better than I ever can, to show that we can then study these technologies and prove that they are cost effective and that they're actually moving the ball forward, and that we're actually doing better and doing the right thing for our patients. So with that, I will end, and I will thank everyone for your kind attention. I'm happy to answer any questions as well.
Wow, Dr. Duvvuri, that was a wonderful lecture, and you've indeed opened our eyes wide to a lot of the new stuff that's there on the horizon, a lot of that we don't normally see or get to know of. The question from Dr. Akshat, I'm not sure if it's directly directed at you, but then he's asked it at this point. He asked that for salvage resections where you don't need to open the neck, are you okay with not ligating the vessels in the neck, or you still prefer clipping the vessels? I'll repeat, for salvage resections where you don't need to open the neck, are you okay with not ligating the vessels in the neck, or you still prefer clipping the vessels?
So I can give a first pass at that. I say for salvage resections, when you do not need to open the neck, I do not specifically explore the neck for clipping the vessels. I clip the vessels transorally. The caveat for this is, and I think Dr. Paleri has probably the most expertise of any of us in terms of salvage TORs, is if the resection is sufficiently deep that I think that the great vessels are at risk, or at least the lingual, etc. If I feel I'm passing more than a centimeter or so into the tongue-based musculature, then I do take it upon myself to open the neck just to clip the vessel. So it is a bit of a judgment, but I don't do it routinely.
Right, right. And a question from my side, sir. You've used the various robotic systems, a lot of them available on the market. Any specific advantages or disadvantages of the single port system that comes to your mind, or something that you would like to share specifically?
Of the single port system you're saying, specifically?
Yes.
Yeah. So, we have not invested in the single port system at the University of Pittsburgh, specifically. And that is not because I don't like it, or I do want it. I would love to have it. But I think, again, I'm the director of Robotic Head Neck Surgery, but I'm also the director of the overall robotic committee for our system, where we have multiple hospitals and multiple surgeons. So we recently upgraded our fleet of 16 Da Vinci SI robots. And so that was a huge purchase and a huge amount of money that was laid out for that. So we took a poll from all of the different surgeons and we said, what do you really want, and what do you like? And the blunt answer was that at least the urologists felt that they could do all of the surgery they needed without the single port. The gynecologists felt the same way. They felt that if we had the single port, they would like it and they would use it potentially, but they didn't really care about the single port specifically. So I think that's one issue at hand. The second is, if you think about the single port technology, the arms are about 7 millimeters in size. They have a sheath on them, which adds just a little bit more of thickness. And then you have to have a working space in which you can actually deploy the camera, which looks like a cobra head, and the arms come from the side. So you have to have a certain working space in order to be able to use this robot adequately. And so getting access to the larynx and hypopharynx, I think, is challenging. I will defer to those that already have the system. I don't have in vivo experience, but my colleagues here who have it have said that it's challenging. And so I think that there are potentially some applications for it. I don't know that TORS is necessarily the sweet spot. I do think that using this for robotic necks, robotic thyroids, etc., might be amazing.
Right. Just a comment from Dr. Paleri, excellent talk, Uma, and your work on haptic feedback should be seminal in defining the future of this modality. So yes.
Thank you. I hope to be able to share those with you in the near future. So I think I would like to leave the audience and the panelists with the sense that the technology is very exciting. Where we are now is not going to be where we finish. This is just the beginning of this wonderful wave. And I really do think it is important for us as surgeons to pay attention to the problems. Don't just go through the work and take care of the patients and do the work. I know it's difficult. Our jobs are challenging. We have a lot of patients and huge lists to get through and huge OPDs that we have to, see a lot of patients. There are a lot of unfortunate sick people in the world, but try to spend a bit of time to reflect and think about what are some of these problems so that you can then help to solve those, because I think that's how we will all potentially make our greatest impact.
Sure. Thank you, sir. And before I move on to the next speaker, just a message for you from one of our anonymous delegates saying that they just love your hair. So no guesses on which gender they belong to. So just on a lighter note.
It's the quarantine hair. I have to say. So okay. I'll keep it going for as long as I can until my wife is sufficiently upset with me.
Sure. Thank you, Dr. Duvvuri. Yeah.
Thank you, guys.
Yeah. So we'll move on to the last of the talks, and thanks to all the delegates for patiently listening in. The next talk is going to be delivered by a very close friend of mine and dear associate, Dr. Gupta. He is a robotic head and neck surgeon, currently working with the Medanta Hospital in Gurgaon. And he happens to be the first Vatikuti robotic head and neck fellow to train under Dr. Tabas. And he's actually done a lot of work on HPV negative oropharyngeal cancers. So on to you, Karan. Your topic for the day is role of TORS for HPV negative oropharyngeal cancer.
Thank you, Harsh, for the kind invite. At the very onset, I would wish to thank the NH Collegium, Dr. Sourav, Datta, and Dr. Harsh for giving me this opportunity. It's a pleasure to share this virtual dais with the world leaders of head and neck surgery. Just a minute. So basically, I've been told to talk about TORS in HPV negative oropharyngeal cancers. I hope you can see my slides. I'll just go on a full screen. Just a minute. Yeah, I hope you can see my slides now.
Yeah, absolutely.
Yeah. So basically the topic that I have been given to talk today is transoral robotic surgery for human papilloma virus negative oropharyngeal cancers. I'll begin with greetings from Medanta, the Medicity in my hospital from Gurgaon, Haryana. So the first question which needs a special answer is, why is this special stress on HPV negative oropharyngeal cancers? And my work has been made easy by Dr. Duvvuri and Dr. Paleri, because HPV negative oropharyngeal cancers is a very separate disease entity as compared to an HPV positive tumors that we have been listening to so far. And this is because of certain facts. And the first and the foremost fact in this is this landmark study published by Yang et al. In 2010 in the New England Journal of Medicine. And this study categorically showed that the tumor HPV status was a strong and independent prognostic factor when it came to oropharyngeal cancers, and clearly demonstrated that HPV positive and HPV negative tumors are two very different diseases with very different outcomes. With HPV positive tumors tend to do very well, whereas HPV negative tumors had considerably worse overall survival as seen in this paper. And the second big factor for this particular stress on HPV negative is this geographical distribution disparity between the incidence and prevalence of HPV infections as such and HPV related head and neck malignancies between the West and the East. As Dr. Duvvuri very clearly stated that they see majority of the tumors in his practice to be HPV positive, whereas in our Indian scenario, only 15 to 30% of all oropharyngeal cancers that we see are due to HPV positive infections. So any literature which is getting generated from the West cannot be directly extrapolated in treatment of HPV negative oropharyngeal malignancies in Indian subcontinent. So with this background, we just move forward. Since the late 90s and early 2000s, the standard of care for oropharyngeal cancers have become radiation with or without chemotherapy added to it, with an aim of organ preservation. And gradually we have shifted towards treatment intensification, which might be by altered fractionation regimes or by adding concurrent chemotherapy to the radiation to improve oncological outcomes. But with all these intensification treatments as well, gradually it was clear that the oncological outcomes for HPV negative oropharyngeal cancers were not as great as for HPV positive tumors. Like in the study published by Yang et al. In 2015 in International Journal of Radiation Oncology, even with radiation and all possible combinations of radiation with chemo or cetuximab, the overall survival was just 45%. And similar have been the results for HPV negative oropharyngeal cancers from around the globe. In all these studies, we can very clearly see that the survivals were worse for HPV negative oropharyngeal cancers when compared to HPV positive, whatever be the treatment modality, be it radiation, be it chemoradiation, be it surgery followed by radiation or chemoradiation. So, and this wasn't the end of the problem. So whatever improvement was obtained and whatever improvement in oncological outcomes were obtained by adding chemo to radiation or making these treatments stronger, there was increased morbidity and mortality associated with these treatment options, and even more for HPV negative oropharyngeal cancers. Like in this paper by Megate et al. Published in JCO in 2008, they analyzed late toxicities for all RTOG trials like 9111, 9703, or 99 and 14. And they clearly showed that nearly 43% of these patients land up with severe late toxicities. Another paper by Hutchison et al. Published in Cancer 2012, where 29 patients, majority of which were oropharyngeal cancers, were treated with radiation on chemoradiation, and 82% of these patients had silent aspiration. And nearly 48% patients presented with cranial neuropathies years after the treatment. So it's not only acute toxicities with the treatment, it's the late complications which can happen years after in such patients, which are of a concern also. Finally, coming to this study by Bledsoe and et al., published in 2013 in Radiation Oncology. This very categorically showed that the survival estimates between HPV positive and HPV negative tumors treated with chemoradiation showed significantly worse rates of local recurrence rates or overall survival for HPV negative tumors. And which was another point which came out with this paper, was that the late toxicities were significantly worse in HPV negative tumors. So the point which needs to be addressed right now is, I agree that these studies were a little old. They must have treated patients with old techniques of radiation. But even with newer modalities of radiation like IMRT, IGRT, VMAT today, the trends would remain the same. Maybe the rates would be lower, but the trends would remain the same. That is, the HPV negative tumors would still do worse in terms of toxicity as compared to HPV positive tumors treated with chemoradiation. So just to conclude, HPV negative tumors tend to be more radio resistant. They have poorer oncological outcomes as compared to HPV positive tumors, and they have more treatment related side effects as compared to HPV positive. Along with that, they have field cancerization, which is commoner, and there are second primary tumors also more common with HPV negative tumors. Hence, there was a need to bring back surgery. And especially with the advent of transoral surgery, be it endoscopic, be it laser, be it robotic, which overcame the issues of the transmandibular approaches for oropharynx, there was a need to bring back surgery. And with the FDA approval of transoral robotic surgery in 2009, this ushered basically an era of robotic surgery. And there were two questions from the very beginning which needed answers. For HPV positive, is there a role of de-intensification of treatment, or can you treat these patients with a single modality treatment like TORS? And Dr. Paleri and Dr. Duvvuri have really given us enough data to prove that patients who can be treated with a single modality TORS are excellent patients for robotic surgery. But what about HPV negative tumors? Can we intensify the treatment for these tumors? Can surgery add and give us better oncological outcome if we treat these patients with TORS and then do tailored adjuvant treatment? Initially, all the literature which came from the West, like this trial from Cohen et al. Published in 2010 in head and neck from UPenn, clearly showed that for oropharyngeal cancers, irrespective of the HPV status, if you do TORS, the oncological outcomes were significantly better as compared to the traditional cure rates or historical cure rates with CTRT. The HPV negative definitely did worse than HPV positive, but still whatever cure rates we could obtain in HPV negative tumors, which were way better than what we could obtain with chemoradiation. Second, another study by Moore et al. Published in 2012 in the Mayo Clinic Proceedings again showed that HPV negative tumors could attain disease-free survival in the range of 89% and a recurrence-free survival in 83%, which was again much better than what we obtained with chemoradiation so far. And the third study by Mahmood et al. Published in 2017 again showed that irrespective of the HPV status, with TORS, the cure rates were much better. Agreed that in all these studies, the overall numbers of HPV negative were very small. Like in Cohen's study, it was only 13 HPV negative patients. In Moore's study, it was only 18. But all these studies brought about certain facts and led to an hypothesis generation. The first and the foremost fact which came out of all these studies were that the poorer prognosis for HPV negative oropharyngeal cancers with chemoradiation was not due to distant metastasis. These patients had higher rates of loco-regional recurrence. Secondly, most of these patients and most of these cancers were tobacco related, and they were similar to tobacco related cancers of the oral cavity. And these cancer cells were inherently resistant to radiation and chemotherapy. As we know from oral cavity cancers that those cancers do not do well with chemoradiation. Similar was the scenario with oropharyngeal cancers, which were HPV negative, because the etiology for them was also tobacco. So this basically put forward an hypothesis that if we upfront do a surgical approach like TORS and remove these cells which were inherently resistant to chemoradiation, can we improve the survival for these patients? Based on this hypothesis, we did the first prospective trial for HPV negative oropharyngeal cancers. And for this trial, we just included stage 1 and stage 2 tumors, and our aim was, again, to provide a single modality treatment for these patients. We included 49 patients for HPV negative oropharyngeal cancers who underwent transoral robotic surgery, and we could attain a disease-free survival of 89% and an overall survival of 93.4% at a median follow-up of 29 months. And that too with a pretty good functional outcome. Like none of our patients were tracheostomy dependent, and only 2 out of 49 patients had long-term PEG dependence. And these were 3 months from treatment. After 6 months, none of these patients were on enteral feed. All of them were taking oral feeds. Based on this trial for early stage cancers, I'm so sorry, I'll just come back. We developed the second prospective trial for stage 3 and stage 4 oral cavity cancers. And this was published in the European Journal of Surgical Oncology in 2009. Here, our aim was to provide TORS-guided treatment for stage 3 and stage 4 patients and see if they do well. So we included 142 patients who underwent TORS-guided treatment and obtained an overall survival of 91.5% and a disease-specific survival of 81.7% at 48 months of follow-up. There were a few important points which came out of this study. The first and the foremost point which came out of this study was that nearly 2/3 of our patients did not require a triple therapy. That is, 2/3 of the patient did not require surgery followed by radiation and chemotherapy. We could avoid radiation in nearly 66% of our patients. And at the same time, a small percentage of patients did not even require radiation, because these were the patients who subsequently got downstaged on the final histopathology. Also, we could reduce the dose of radiation which was given to this cohort, and these patients received only 60 grays as an adjuvant setting rather than 70 grays in upfront concurrent settings. All these parameters played a very important role in improving the functional outcome in our cohort. And as you can see, none of the patients were tracheostomy dependent, and about 4.5%, that is only 7 patients, had long-term enteral feeding requirement. Again, at the end of 1 year, none of these patients required enteral feeding. So similarly, based on this concept of TORS-tailored adjuvant treatment and with an aim of de-intensification of treatment, especially in HPV-positive oropharyngeal cancers, the phase 2 AVOID trial was published by UPenn Group in 2020, where they totally avoided radiation to the primary site if there was no indication after surgery, and the neck was radiated with 54 grays to the low risk area and 60 to 66 grays for high risk areas with excellent functional and oncological outcomes. Similarly, many de-intensification trials are on and have been discussed in detail by Dr. Paleri and Dr. Duvvuri. And not just similar results for HPV negative patients were obtained by groups in Korea as well, which showed an overall survival of 88.8% and a disease-specific survival of nearly 90% at 5 years for stage 3 and stage 4 cancers. And another important thing out of this paper was, again, 50% of their patients could also avoid chemotherapy. So basically, for HPV negative oropharyngeal cancers, TORS can help for proper risk stratification and tailoring the adjuvant therapy based on actual pathological staging, and with an aim of improving the oncological and functional outcomes with minimizing the treatment-related morbidities. We all are familiar with this old study of 1994, which showed that what we see clinically, or the clinical staging and the pathological staging, are different. Like there is a chance of 30 to 40% false positive neck nodes that we overstage these patients clinically, and subsequently these patients might get overtreated with chemoradiation and lead to a poorer quality of life. What is more concerning are the false negative rates of about 20 to 30%. These are the patients who have no indication of neck nodal disease on any preoperative imaging. You stage them as a stage 1 or a stage 2 disease, and they are treated with only radiotherapy, and they might be harboring microscopic disease in the neck, and so this treatment might be an under treatment, leading to poorer oncological outcomes. Thus, for such cases, TORS with neck dissection can pathologically stage the neck for precise treatment. This has been the question which is being answered by a lot of trials in the West, that for early stage HPV positive oropharyngeal cancers, can we improve the quality of life by de-intensification of treatment by TORS? Absolutely. Like patients which can be treated with a single modality treatment of TORS, where you can avoid long-term side effects of radiation, or you can decrease the doses of radiation, would definitely do better functionally as compared to any patient receiving full dose of radiation. But at the same time, for HPV negative tumors, can we improve the survival by TORS guided treatment? I would say absolutely again, because with TORS guided treatment in such patients, you can give tailored treatment to the patient. You treat the patient as to what exactly the treatment they require, not a blanket treatment of chemoradiation or radiation to all these patients. For a higher stage disease, the patient will receive a higher stage of treatment. To conclude in the end, all I want to say is that TORS is a safe and effective treatment. HPV negative and HPV positive oropharyngeal cancers are two different diseases altogether. The functional and oncological outcomes of HPV negative oropharyngeal cancers tend to do inferior as compared to HPV positive cancers with radiation or chemoradiation. Intensification of treatment with HPV negative oropharyngeal cancers with TORS may give better oncological outcomes, and TORS guided treatment with tailored adjuvant treatment might be the way forward. Thank you.
Thank you, Karan. That was really very insightful, and you made very insightful points, very relevant points about HPV negative oropharyngeal cancers and the role of TORS. And you've done great work with this exact disease profile. There are a lot of questions which are popping up. Some maybe for you, but some I feel.
Can I ask a question with your permission?
Absolutely. Yes, sir. Please go ahead.
Karan, a small query. When I heard your presentation, when you say staging, you are just staging the neck. Okay, so you could achieve that by just doing the neck dissection and not just touching the oropharyngeal part. All this information can be it. What do you say about that?
So that's a very valid point. But see, we would, again, this staggered surgical technique of just doing neck and not doing the primary is again not very acceptable and prevalent. You would basically be taking these patients for any surgical management if the primary is also surgically resectable, like a T1 or a T2 primary. I'm not advocating surgical treatment for a T3 or a T4 primary where the TORS might not be feasible. But yes, your point is absolutely valid. For a bigger, higher staged primary, you can just do neck to stage the neck properly. But I don't see the benefit of that. If it's a T3 or a T4 at the oropharynx, it is any which ways a stage 3 or a stage 4 disease collectively, irrespective of the nodal status for this patient. And this patient would be chemoradiated. The point of operating such patients is to see if you can downstage and decrease the treatment intensity for these patients. So if it's an N0 clinically and pathologically also it is N0, then you have a case of just radiating if required and not giving him chemoradiation. So that's the point I wanted to bring forward.
Right. So just a quick question for you, Karan, before we move on to the much awaited panel. Do you see any differential outcomes for tongue-based tumors versus tonsil for HPV negative?
Not exactly. Our subsite analysis really didn't show any differences between tongue-based and tonsil. Both of them did almost similarly, but we had more tongue bases in our cohort rather than tonsils. So yeah.
Right. Okay. Thanks, Karan, once again. We're slightly short on time. There was a lot of more discussion we could do, but we'll move on to the panel. Excellent talk once again, Karan. Really appreciate.
Thank you so much.
Yeah, we move on to the panel, which is going to be moderated by Professor Deepa Nair. She is a professor of head and neck surgery and robotic surgery at the esteemed Tata Memorial Hospital, Bombay. And she has a stellar group of panelists. Ma'am, over to you.
Thank you, Harsh. I think it was an absolute pleasure listening to all the 4 lectures now. This panel, I think the talks have created more confusion to some of them and clarity to some. So let me just share my screen quickly. When I just try and share my screen, just a minute. For some reason, it's not showing up.
Karan, have you stopped? He stopped, right? He stopped.
Oh, no,
ma'am, are you able to see?
Yeah. Can you see my slides?
Yes, ma'am, we can see the slides.
All right. Okay. In addition to the 4 stellar speakers who are there today, I'm very honored to have Dr. Anil de Cruz, who is the UICC president, director of Apollo Hospital, ex-director Tata Memorial Hospital, and my boss and my teacher onto the panel. I also want to welcome Dr. Sarbani Ghosh-Laskar. She is the only radiation oncologist in this heavily biased panel of surgeons, but I'm sure she'll hold her weight against all of them. And Dr. Rajeev Sharan, who's a head neck robotic surgeon from Tata Medical Center, Kolkata. Unfortunately, Dr. Devendra Chowkar had some personal commitment and could not join the panel. So welcome all of you all. And while I think this is an EBM weekend for us at Tata Memorial Hospital, and I just borrowed the slide from my colleague, Dr. Ashwin D'Souza, and I think it's a very relevant slide. He said, we had a very good technology meet yesterday, and which whole session was dedicated on robotic surgery for the various subsites in the body. And he said very clearly that for any new treatment modality to become standard of care, it should fulfill at least one of the following objectives, that either the patient should be able to live longer or they should be able to live better. And whenever we do all of this and you're comparing it to standard existing of care, that is survival and quality of life, you also try to get it at a lower cost. So I think that's something which we need to bring out. And yes, technology, this is a robotic surgery panel, so it's very technology driven. But let me just come back to what the controversy is. And I think Vin stole the thunder from my wings when he put up all these slides. Orator 2, the only randomized trial really comparing transoral robotic surgery versus radiotherapy upfront. Again, this trial, the secondary outcome was overall survival, and they found no difference in the 2 arms. This was for early stage oropharyngeal cancer. But like Vince showed us, there was a non-clinically meaningful difference favoring the radiotherapy arm when you're talking about quality of life outcomes. So swallowing was much better with radiotherapy, unlike what we expected with TORS in these patients. They again designed a phase 2 randomized control trial. Now this was looking at progression-free survival in the same sort of groups, and has really dissected the trial very well. But like he pointed out, this trial has recently been closed due to toxicity in the TORS arm. So my question to Sarbani is, Sarbani, as a radiation oncologist, do you think your position has been vindicated? Do you think this is the end of road for TORS for oropharyngeal squamous cell carcinoma?
Because I personally feel, and even based on the evidence that's available, that this is the end of the road for TORS. I think TORS in the suitably selected patient is an appropriate tool. So just based on this trial designed to study 72 patients, which has been closed prematurely, I don't think we can say that this is the end of the road for TORS.
So I think that's very heartening to listen from the radiation oncologist that we still can think about TORS. So let me just show you results of a quick survey we did recently. It was an online survey, anonymized, among practitioners of head and neck cancer in India. And we just asked them simple questions. What is the proportion of HPV positive oropharyngeal cancers in your practice? And if you see, only around more than two-thirds of them had less than 20% of patients being HPV positive. And again, like Karan said, most of the patients have base tongue cancers more than tonsil or soft palate cancers as a part of practice. So our population may be slightly different from the population seen by Dr. Paleri and Dr. Duvvuri, which possibly favor more HPV positive tumors and more tonsillar tumors compared to base tongue tumors. And this is what we want to keep in mind when we start this panel. Now, this panel, there are lots of PG students and trainees and postgraduates on the attendees. So I would like you to just go down over some things which we've already discussed in the lectures, emphasizing on ideal selection for these patients. Let's just quickly do a case-based discussion. The first case is a 48-year-old male. He's a smoker, diabetic hypertensive, complaining of some difficulty in swallowing for the last 3 months. When we did a flexible scopy, there was a lesion in the base of tongue. You can see that it was on the left side, the vallecula was free, just reaching the circumvallate papillae anteriorly, TLS was free, and just reaching the midline on the flexible. It was a moderately differentiated squamous cell carcinoma, which was P16 negative. And if these are the scans of the patient, you can see there's this enhancement here. Not a very deep tumor, not going into the genioglossus, but a fairly large tumor, which is just short of midline or just reaching the midline. Patient was had one node which was not clinically significant. So my question to the panelists, and I'll start with Karan, because he gave a wonderful talk on P16 negative tumors. What would your treatment choice for this patient be? Or
so this is being a TORS panel, my treatment of choice for this patient would be to do a transoral robotic surgery and a selective neck dissection. It looks a well localized tumor. It is not very deep. It is reaching midline, but I think we can get laterals, the midline soft tissue margins safely without injuring the lingual on the contralateral side. And the neck would be selective level 2 to 4 with some clearance of level 1 lymph nodes, but I always tend to preserve the submandibular gland in situ.
Okay. KK, would you advocate TORS for this patient as well?
Yeah, actually, in our part of the country, we have very few percentage of such cases. So we don't encounter such patient, but I would raise my doubts in selecting TORS for this patient. Okay. My question are we going to do a bilateral neck dissection in this patient? Okay. And what percentage of these patients will have node positivity, and what percentage of patients will have near positive or close margins, and what percentage of patients will undergo adjuvant treatment in this case?
So KK, let's hold on to those questions one by one. Let's first decide whether this patient is suitable for TORS or not. Can you quickly enumerate what are your criteria for operability for a patient for TORS? When you look for a patient, I'm going down to the basics because there are PGs on this panel.
Right. Yeah, localized lesions which is not very thick and not going beyond, if it is a tonsillar tumor, the constrictor involvement, and the tumor should not cross the midline, and of course it should be an accessible lesion for.
Rajeev, I've put up some of these criteria. Does any of them really determine, other than maybe the mouth opening, does any of the others really influence your decision on TORS?
This patient, because this tumor is coming till circumvallate papilla. So in that case, resection will be quite large resection. So definitely I will go for reconstruction, some kind of reconstruction in this patient. And apart from that one, P16 status, obviously that will be prognostically better tumor. And age, if it is more than 70 plus, so chances of aspiration will be there in this patient. So it will take some time to recover swallowing function.
So let me understand, if the patient had disease where you are doing reconstruction, you would not offer TORS. If the patient has age which is more than 70, you would not offer TORS. Is that what you're saying?
No, patient should be told about all these problems. So obviously, like if you are going to resect in this patient, definitely I will discuss reconstruction as part of surgical procedure. Because if it would have been like away from circumvallate papilla, then obviously I would have just done TORS. But if it is reaching till circumvallate papilla, then in that case, part of your anterior tongue also will go with this in this resection. So that will be quite large defect in this patient. So at the same time, if you are discussing TORS, then obviously at the same time, I will discuss about reconstruction in this patient. So my facial flap or some local flap that can be done. So that that will take hardly 1 hour or so.
Dr. Paleri, would you agree with this? What are your indications to do TORS for this patient? Would you do a TORS for this patient?
So this isn't an easy case, Deepa. Normally panels means first case is meant to be easy, then you rack up the pressure. But okay, on a serious note, this patient would have a robust discussion at our MDT. These are my thoughts on it. There's a nice propensity-based analysis of HPV negative tumors managed by primary upfront non-surgical modality or primary surgical modality followed by adjuvant treatment based on margins and everything. 103 patients, very nicely matched, not a randomized controlled trial, but almost the next level of evidence below an RCT. So very nicely matched for age, stage, comorbidity, sex, and everything. It showed a 13% difference in survival in patients who underwent upfront surgery for HPV negative oropharyngeal tumors. That's point number one. And then I think about my experience. I have a large salvage practice. I'm sent patients from a large geographic region. I do not see patients sent in for salvage who have ever been managed surgically. Either they don't recur, which is unlikely, or maybe they're not salvageable, which may be feasible, which is a possibility as well. But I'm not seeing patients who are treated by upfront surgery being sent in for salvage. So with that in mind, and he's young as well. So if his mouth opening is good, and you told me it's a T2 tumor, I know it goes across the midline. It doesn't necessarily, it shouldn't prevent you from accessing and taking a bit of a tongue base away with it. Here on the scan, there is no hyoglossus invasion. I'll come to that in greater detail if required. The tonsil is free, only the tongue base is involved. And I think the chance of getting a negative margin in this man is reasonable. You won't get your 5 millimeters all the time, but a chance of getting negative margin is high. So with that in mind, I would counsel him. I tell him chemoradiation is a very good modality in this setting. But I personally feel, based on my experience, that he's perhaps better off with upfront surgery followed by adjuvant radiation. He's young. His functional abilities are good. So his ability to recover from the surgery and the radiation and have good function is high. Survival is key for him. And I would therefore steer him along the line of offering him upfront surgery followed by radiation therapy. I would do both next, by the way. And I wouldn't reconstruct. I don't think there's a need to reconstruct T2s at all. They do well with it. And the tongue-based musculature on the other side actually hypertrophies to compensate in the longer term.
So the point of this tongue-based resection, can you just elaborate? Why is the fear of resecting across the midline for oropharyngeal cancers?
So the worry is about damaging the opposite lingual artery, isn't it? But realistically, that won't happen. At worst, you may possibly clobber the dorsal lingual vessel, which doesn't matter because you've got the deep lingual artery to supply the tongue, and one side lingual is fine. I've been there many times. I've been there times where I've Dopplered the dorsal lingual, resected that, and left one lingual for the entire tongue. It works. So the chance of damaging the opposite main trunk lingual or deep lingual is low. So with that being the case, it is feasible to resect this. So I don't think we need to be unduly concerned about losing vascularity to the tongue in this instance, if you were to do upfront transoral robotic surgical approach.
So that's a good point made. Dr. Duvvuri, this is the patient's mouth opening. Even under anesthesia, the patient had a best of 3 centimeters mouth opening. And this is a very common situation in our part of the world where patients have submucous fibrosis, they are tobacco users. Would you recommend any alternate mouth gags, or would this be good enough for you to operate on these patients?
Yeah, most of the time,
That's a curveball.
Yes, it is. But I would say that most of the time, 3 centimeters of mouth opening, is okay. I think that it depends again on the system that you're using. Clearly, more is better. So wider mouth opening clearly leads to better exposure. Using the SP robot, one may have challenges getting it docked into the mouth with the 3 centimeters of mouth opening. I don't have a lot of experience with this, but it seems to me that having that cobra head shape that requires the working space may be challenging. With the SI, I think that this is definitely very tackleable.
So just a show of hands, does everyone use the FK retractor or someone uses something else locally made? Because this may be a concern. So all FK retractors, even we use the FK retractor.
So we have the Lars and the FK, and it's definitely better and easier to work with FK. Lars tends to be a little bulkier, and the working space is less with Lars as compared to FK. For such patients who already have submucous fibrosis, FK would be a better choice.
I personally don't use the FK at all. I never use the FK except for supraglottic tumors. I find that a simple Crow-Davis or Boyle gag is absolutely sufficient, and I find that it is less bulky and cumbersome. I think the key here is when you have small mouth opening, you really have to make sure that you use every millimeter of space that you have available, because otherwise you will encounter collisions, and that is very frustrating and will challenge the operative surgeon.
So coming to the issue of margins in TORS, we've heard very good talks by Dr. Paleri, and even Dr. Duvvuri referred to it about margins. I think Karan talked about margins as well in negative tumors. Now, with apologies to Dr. Paleri, I copied down his slide. A lot of studies are looking at role of margins, and they've defined, as he very well put it, different studies have different margins, 5 millimeters, 3 millimeters, 2 millimeters as adequate margins. But all these patients on these studies are HPV positive. Dr. De Cruz, what is your take on this? Should we change our margins for HPV negative tumors based on HPV positive studies?
Deepa, as Vin said, these are very tough clinical situations. But I'll tell you, when Harsh invited me on this panel, he said, "Sir, take them all on. Whatever they say, you've got to give us the opposite view." In my book, I practice evidence-based medicine. And a patient who's HPV negative today will not go for TORS in my book. There's not enough data, however compelling Vin might sound, however compelling Karan might give you his logic. I also love this slide of yours where you showed that 2/3 of people had less than 20%. But to me, and you can tell me Tata Hospital data, the HPV positive patients that we see, who are truly HPV positive, like the ones that Uma and Vin see, are in single digits, and there are enough publications. We see patients who are HPV positive, but those are smokers, tobacco users who may express the P16. So I'm not sure if we have any data for that as well. So in my book, all these patients would have gone for non-surgical modalities. And I think we need to give that message to youngsters, as you kept repeating, the youngsters listening. If you're an adept robotic surgeon, go ahead and do it in a protocol setting or in a prospective setting where you monitor your data like Surendra and Karan and others are doing. Otherwise, don't get swayed by these 4, what was the word you used? Stellar panelists, huh? The 4 guys who spoke. The 4 stellar panelists telling you to go in with a 3 millimeter mouth opening or 3 centimeter mouth opening and make a hash of this case. I'd like Sarbani to come in here before we move on margins.
Could I ask Anil a question? I hate to disagree with him. I know you're going to bring Sarbani. Just one question.
Please, go ahead.
Yeah.
So Anil, you mentioned there's a lot of evidence for managing HPV negative cancers non-surgically. Where is that?
So
I
I'll
haven't
tell
seen
you
a phase 3 trial on that.
They won't be. You're sounding like Greg Weinstein. You'll tell me that you don't show me a phase 3 trial operating oral cancers upfront is correct. Just show me one trial. There are certain things like if you drop a brick from the building, it's going to drop down. It's not going to go up. I'm not going to give you a randomized trial. But let me take you back in history when you must have been in high school then. There were a lot of things that changed. There was the RTG 7003 trial. Tuk Chong was the first author. And they did cause a paradigm shift saying surgery followed by post-operative radiotherapy is what needs to be done for all patients. And a lot of laryngeal and hypopharyngeal and various other cancers went for upfront surgery. But then we realized two things. There was a paradigm shift with VA and others that changed larynx, hypopharynx, and oropharynx had to be compromised because of morbidity of surgery. So in my book, if I can get out an oropharyngeal cancer with absolutely clean margins, it's small, it's a T1 tonsillar, I may consider surgery upfront. This is for HPV negative. Otherwise, I'm not going to send this patient. Look, among 4 or 5 of yours, including Rajeev, he wanted to put in a flap. We don't know what the margins are exactly. Deepa has shown you so many differences in margins for HPV positive. And I think there is data that oropharyngeal margin cannot be 2 millimeters. Again, may not be prospective data. I would not want to compromise a patient who even has a T2 with a close to 20 to 40% chance or even more of having lymph node metastasis. And if he has a base tongue, it will be bilateral metastasis for larger lesions. I mean, we can keep arguing till the cows come home, but looking at the lesion that Deepa showed and confidently saying, I won't hit the opposite lingual, I'll get a margin, to me is very, very difficult. I know you've done a lot, but there are times when you will have some disease going back, and I'm not sure how you can make these strong statements. So for me, this patient will go for non-surgical, given the current evidence. I hope it will change in the times to come, and probably I'll discuss when we go into the HPV positive as well.
Sarbani, would you want to get in out here?
So I kind of agree with Dr. De Cruz, despite the experts saying that this would be a lesion that would be amenable to TORS. My concern here is that we really don't have people who would do TORS the same way. So if this patient were to go to 100 radiation oncologists, 100 oncology centers, forget radiation oncologists, I don't think we have the expertise available. That's my first concern. And also looking at the lesion per se, I don't think we could get away by doing just plain radiotherapy. And even after surgery, there would be a high proportion of these patients who would require adjuvant therapy or trimodality therapy. That's my concern in this case. So I would rather reserve TORS for salvage rather than use it up right in the beginning. But yes, having said that, I have always been, if you remember, Deepa, I always say that if you guys could actually do TORS or surgery for base tongue, I would be very relieved, because these are the lesions that don't do as well as the tonsillar lesions. But if you look at this case, I would say that CTRT would be the treatment of choice for me also.
So unfortunately,
I apologize to come back again. I hate to disagree with both of you, but to summarize, Anil's concern about not offering surgery is because of lack of expertise and morbidity, and likewise Sarbani's concern is about lack of expertise. So it's not that we are truly saying it is not indicated. Let's clarify that point completely. If it's truly lack of expertise, then there is a need to perhaps.
No, Vin, I'm going to interject here. You very elegantly showed the Orator trial and showed the points that you wanted to say. Tell me, in the Orator trial, out of the 34 patients on the TORS arm, how many were pure TORS?
If I recall right, it's 30% or so.
No, I'll tell you. Yeah. So 10 of 34.
Yeah, 10 of them.
All. And mind well, these are patients who are low risk or intermediate risk. So when you have these patients who are HPV positive, a different biology that all of y'all have driven so strongly, you needed to supplement 2/3 of patients, 70% of patients with something else. And if you're going to tell me that that supplement for HPV positive is adequate for HPV negative, then we'll have to go back to the drawing board and change the AJCC 8th, where HPV negative and positive are different diseases.
No, I'm not saying that at all. I'll stop with this last comment, Deepa. I'm not saying that at all for a minute. All I'm saying is, and I'm not for a minute saying these patients, I'm avoiding post-op adjuvant CRT in this patient group, not at all. I'm saying we should treat oropharyngeal HPV negative cancers the way we treat oral cavity HPV negative cancers, because adding surgery to the mix increases local control. And these days, we can achieve that surgical procedure with lesser morbidity compared to what that old Parsons paper showed in cancer in 19. So that's
point well taken, Vin. And I'll conclude a line that I did make, that as of now, the treatment is non-surgical. If you are doing it on a prospective in a high volume center with excellent infrastructure like Karan and Surendra are doing, capturing the data well, you have the expertise, then do it in that setup. Don't listen to this panel and tomorrow go dock the robot for a patient like this. The first bite of the cherry is the sweetest.
We agree completely on that last sentence. Absolutely. So, I'm totally behind you.
So thanks, Vin. Yeah, thanks, Vin. Vin agreeing with me calls for a drink. I'm taking a break. Go ahead, Deepa.
So I think these questions are not going to be answered. Unfortunately, there was a trial started by the RTOG in the same subgroup where they looked at intensifying treatment based on risk-adapted adjuvant therapy for HPV negative, but it was closed early due to lack of accrual. I think Karan has shown good data on their cases, which is again very prospectively maintained, well-done cases where they've shown that possibly even in the HPV negative setting, in good hands, you may have good results. Now, again, just coming back to the question of margins and TORs, there are still lots of issues, and I'll bring Uma in here. This is your paper, Uma, and again, when we talk about looking at this paper in the subgroup analysis, the patients which are a concern to us, the base tongue lesions, which form most of our population, had a very high margin positivity rate. And this is where Sarbani will hold a gun to my head and say, you're giving me a margin positive patient whom I could have treated with radical radiotherapy or chemoradiotherapy upfront. Now is going for trimodality treatment. What's your take on this?
So I think that that's a very fair point. I think that the margin positivity rate in this particular paper was somewhat biased by the retrospective nature of the disease and the time frame during which this disease was done. I think that it's important to look at the margin positivity rate now on the larger series, and again, I'm referring to 3311 because while we may not be able to accept 3311 as paradigm changing, which I disagree with Vin on that particular point, or we could get to that later. I think what we can find out is what is the acceptable rate of positive margins with a prospective trial with 500 patients, all of whom underwent surgery, with greater than 60 surgeons in 15 different centers. This is a cooperative group trial, so we should be able to get a better sense of what the actual margin positivity rate is, and it'll be closer to 6%, not 20%. I think it's because we've gotten better at doing surgery.
So I think we'll look at the ECOG Akron 3311 data will come, and maybe it'll get some idea about HPV positive margins. Again, for HPV negative margins, the jury is still out. I don't think we can really extrapolate data directly from HPV positive to HPV negative, and we need more studies. So let's move on from here to the next.
If I may actually just make one small comment on that, I think that's a very, very important point of extrapolating between HPV positive to HPV negative disease. They're fundamentally different diseases. And so if we just take a step down, a trip down memory lane, when we think about the Bernier trial, the Cooper trials, which actually define the role of chemotherapy, cytotoxic chemotherapy in the adjuvant setting, those were all based on HPV negative patients by and large. At that time, we didn't know about HPV positive. The oropharyngeal cancer patients in those particular groups were very small. The majority were based on HPV negative disease, oral cavity and larynx. And so even when we think about 3311, when we think about pathos, when we think about best of or orator, et cetera, and we think about giving these people chemotherapy and radiation, which are again based on data from Pignon and the EORTC groups, et cetera, much of that data is extrapolated from HPV negative disease. A lot of what we think about the treatment of HPV positive disease now, the paradigm, what we call the standard of care, is from HPV negative, and there's no data really to suggest that. So if we want to be evidence-based, we really, I do think, I agree with Anil, we have to just blow it up. There should be a completely new disease, and we should have to repeat all of the data with the context of HPV positivity, or go back to those retrospective or those prospective trials, look at the pathologic specimens and find out how many patients were truly HPV positive and did it make a difference. I think we would find that it doesn't make a difference. But that's just my commentary.
So great points here. Just moving on to the second case, because I think we are very delayed already. This was a 26-year-old male with no comorbidities, no habits, and presented to our OPD with a swelling in the right neck since 4 months. On evaluation, he was detected to have a tonsillar mass, which was around 2.3 centimeters. It was P16 positive with a fairly large node. So show of hands, who would offer TORS for this patient? Or this is a stage 3 cancer. I'm not by the AGCC staging, but yes, it's a large tumor with a large neck node. Would anyone offer TORS for this patient, or this patient goes up front CTRT? This is a P16 positive tumor. Very small primary, well resectable. I'll just move this here. And it's very, with good margins, you'll get the primary out, but the node is the problem out here. What would you do for this patient?
You know, with CTRT, if he's going to fail, he's going to fail in his neck, more likely. And that's going to be a much more difficult salvage option in dissecting out such a large neck node which has failed in a post-CRT setting. So again, we'd have a discussion, and my oncologist, when they're faced with an N3 neck, they'll say, can you take this out, and I'll mop up whatever needs to be done later. And I would, at the same time, do a TORS and take a tonsil tumor out. He's young, he's going to recover, he's going to do well from a surgical perspective. It's got a good physiologic reserve, and we give him adjuvant post-op CRT, given that particular setting, and that's for both sides too, as appropriate. What about KK or Rajeev?
Our management would be concurrent chemoradiation and doing a PET scan at 3 months. And if node is persisting, we'll go for a salvage neck dissection.
Rajeev?
This patient, because large is not, so obviously patient requires modified neck dissections apart from TORS. So both options I will give to the patient, and final decision after consulting MDT I will take.
Okay, so you would err towards CRT. So Dr. De Cruz, a lot of people would agree with you.
Could I just interject?
No, but I just want to make a comment on this again to place things in right. The upfront neck dissection, which Bob Byers popularized in the 90s, subsequently changed. If you look at how the neck was treated, the RTOG study, Ali and Forestier's. Hello, am I heard?
Yes, sir.
Okay, I think my AirPods have gone. But anyway, the RTOG, Ali and Forestier's study did give people a chance to do a neck dissection 6 to 8 weeks after treatment of CTRT as a salvage. But that's because you did not know how to assess the neck post-operatively. They wanted to do it before fibrosis came. And Hesham Mehana's paper changed it all with the PET as a good negative predictive value. So today, upfront neck, even for an HPV negative, is not standard of care. It was when I was younger. I've got a publication on that, what I call split therapy, plucking out the neck node and then going ahead for radiotherapy. But again, I must say it's not evidence-based to do it today, even for the HPV negative, HPV positive. So for me, again, it would go ahead just because my radiotherapists say that if you take it up, I'll mop it up, doesn't mean it's better treatment. For me, it will be CT-RT very strongly.
So if you look at the PET neck, if you look at the PET neck data, N3 forms a very small proportion of PET neck data. You cannot extrapolate PET neck trial data to the N3 neck.
Granted, Vin, but if you look at Bob Byers, who started the concept, all patients who had nodes more than 6 centimeters, a lot of them needed Ryle's tubes, a lot of them had the external carotid taken out, a lot of them had nodes where you couldn't start radiotherapy within 6 weeks. So I can give you a conflicting data as well. But generally, the logic is that you extrapolate it a little scientifically. I agree, N3 was a small percentage in PET neck. The point I'm making is that you're able to assess the neck accurately and go in for a salvage. And patients who are not complete responders in the neck, whatever you do will fail. Just because you operated them first is not going to improve outcomes. There's just no data to back that approach.
Sarbani, do you have a take? I thought you had a point to make here.
I would actually agree with doing CT-RT upfront and reserving surgery for salvage.
So in this patient, but after MDT discussion, we went ahead actually and operated the patient. Now, before we talk about the particulars of the histopathology, Dr. Paleri, you said you will operate the patient. Could you do a bilateral neck as we've done, or because a lateralized tumor, just a unilateral neck dissection? When would you do bilateral neck dissections?
So, this is something we've explored in a slightly different setting. And N3 is a rare presentation in our practice. So I'd be quite concerned about extrapolating that data we performed, we generated on a cohort with N2 disease. So in patients with N2 disease, we performed a contralateral neck dissection, cleared 2 and 3, and showed that the PN plus status in that setting was very low at 3%. So if this man had smaller neck disease, we'd consider that. But in this guy, I think we'll discuss. I've discussed with Sarbani and my oncology colleagues, and I suspect even if I take out contralateral nodes, given the N3 disease, we'd be much more comfortable radiating the opposite side.
Okay. So this was the histopath report, and we had taken out the tumor. The margins were revised on table because of some cautery issues, and the revised margins were additional 4 millimeters. So we had 5 millimeter negative margins. And very surprisingly, such a large node, there was no N3 extranodal extension. So this patient, by virtue of being HPV positive, was staged as T2N1. Now, my question to Sarbani is that now this patient has undergone TORS. Would you consider reduction of radiation to the primary site to reduce or spare the Dhar structures in this patient? He is a P16 positive patient.
Just have initial evidence from the ECOG 3311 and some data from a void that we could possibly spare the site of the primary radiation, from primary radiation. But you know, this is trial data, and in practice, I would be a little wary of extrapolating it to our patients. So as of today, what I would do is again give 60 grain 30 fractions to our patients. And of course, the opposite contralateral side of the neck would receive lower doses. Of course, there is emerging literature to say we could reduce further, both from the RTOG, from the trial by David Sher, which has actually looked at reducing the doses to 60, 54, and 48, and even lower doses of up to 30 gray. But I would be a little wary of doing it in my patients just now, because these are all short-term data that we've seen. But yes, there is emerging evidence to kind of support doing lower doses, especially to the uninvolved neck, because that is going to bring down toxicity sizably. And of course, in this situation, considering the location of the tonsillar lesion, I'm sure I could do quite a bit of Dhar sparing in this patient also with IMRT.
could I ask a question?
Yes,
to
Karan.
Dr. Same patient, just a similar scenario. Rather than a 6 centimeter node, the node is about 4.5 centimeters. And according to the AGCC 8th edition, this would be staged as stage 1. It would be a clinically N1 node. Will that change your upfront treatment options from chemoradiation to radiation for this patient based on the staging by AGCC 8th edition?
You mean because it's a stage 1, I do RT alone?
Yeah.
Now, see, if you have tonsillar lesions with, yes, there is some evidence from Brian O'Sullivan's initial paper of just doing ipsilateral neck and not treating the contralateral neck in these early stage 1, stage 2 tumors. There is evidence for that. Yes, I agree with you. And the results are kind of equivalent to what we have with the TORS. If you remember the last publication, which was HPV based from Brian O'Sullivan, there is evidence to suggest doing RT alone for these ipsilateral tonsils, which involve less than 1 centimeter of the base tongue or the soft palate. There is evidence for that too. Yes.
Yeah.
But I just want to make one comment again for the postgraduates. I think we're talking about sort of high level treatment in very high level and specialized centers with very experienced radiation oncologies like Dr. Ghosh. But the reality is that the AJCC 8th edition is a staging for 8th edition, but we treat based on 7th edition, right? The data does not advocate for us to de-escalate treatment because you're calling somebody a stage 1 on 8th edition when they have N2C disease, for example. Recall that N2C disease still puts somebody up to N2, and if they have a small primary node, they may be stage 1 or stage 2. So just for the postgraduates, we stage based on 8th edition, but we treat based on 7th edition.
I think that's a very good point, and
very well put, Uma. I'm glad you said that.
Okay, so the last question before we move on to thyroid, as in interest of time, is that would you do a bilateral tonsillectomy? Because in HP, there's an incidence of up to 3% uptake in the contralateral tonsils. Would anyone do a bilateral tonsillectomy in this situation?
Yes, I routinely offer bilateral tonsillectomies to these patients because I don't think it changes the morbidity. I'm not doing it from an oncologic perspective necessarily, although there is some data that HPV positive tumors have field cancerization, just like HPV negative. There's no reason to think, for example, if this is truly HPV positive, that the virus just infected the left tonsil. Right? There's no reason to think that the virus only infects the right tonsil or so on and so forth. There's some reason that only one tonsil develops the malignancy, but there is a potential for multifocality of disease. We're currently studying this. The second thing is more practical, which is inevitably these patients will undergo a PET-CT scan somewhere at some point in their time, and there will be some read that says, contralateral tonsil is lighting up. There's a mass in the left tonsil if you did a right tonsillectomy because the radiation oncologist or radiologist didn't read properly the operative report, and then you end up chasing your tail. So I do bilateral tonsillectomies for that reason.
So that's a good point. A lot of the asymmetry is what a lot of radiologists would report. So if you have a patient who's undergone TORS or a unilateral tonsillectomy on follow-up, be sure that you don't overestimate the opposite normal tonsil as disease just because of the asymmetry. Okay, quick question about hemorrhage, because there has been some questions in the chat box regarding the same. This is again a data from 2017, 509 patients of TORS. If you look at this data, 3% of the patients had to go back to the operating room for control of hemorrhage, and 2% actually had severe complications requiring embolization or tracheostomy. We've seen data from Orator, which is showing, as well as the 3311, which shows that one patient died in the TORS arm, both in Orator 1 in 3311. So from the experts, what are the steps you do to prevent this fatal hemorrhages in these patients? If you could just enumerate them once. And this is open to Uma. Maybe we can start with you.
Sure. So yes. So after 3311, because we were one of the largest enrolling centers in 3311, we had a patient that died. It was not at my center. It was at one of the other ones, but we analyzed the data, we looked at it, and we realized that one death was one too many. And so we started thinking about why we should have, or how we can control this. We went back to the anatomical laboratory, did some dissections. We found that the major source of the most likely source of bleeding based on anatomy would be arterial supply to the tonsil and the tongue base. You can have venous bleeding as well. That can be devastating. IJV blowout is just as bad as a carotid blowout, maybe not in terms of pulsatile nature, but in terms of volume, it can be quite devastating. So these steps do not control venous bleeding, but for arterial bleeding, we ligate the branches of the carotid artery at the lingual and facials for all of our patients. After having done this, the ECOG 3311, again, prospectively, we instituted this as a strong recommendation. In fact, we mandated it. We had 0 complications of major bleeding, return to the OR, or death after that. So that's in a prospective fashion. We know that data. Anecdotally and retrospectively, the groups at Pittsburgh internally, we published on this, Ohio State, Penn, and in Europe, and everybody has found that ligating vessels, end vessels, leads to a basically elimination of fatal bleeding. So the interesting point of Orator 2, I know we're going to get to this, is why did they have fatal bleeding even after tracheostomy and ligation? It's a very, very surprising result, I would say, and something that I would not have expected. This must be a statistical anomaly from the best of my thoughts.
So coming to the question of tracheostomy, Karan, you seem to have a slightly higher number of tracheostomies. Do you do it upfront for patients, and what would be your selection criteria? I know our threshold for tracheostomy at Tata Memorial Hospital is quite low. We'd rather have the patient have a tracheostomy which can be decannulated in a week's time rather than having fatal bleeding and losing the patient that way. So Karan, can you talk about your rate of tracheostomy in your study?
So, yeah, so that was exactly our reasons of doing tracheostomies for such patients. That initially in our practice, our concern was also post-operative hemorrhages. So rather than sending these patients intubated overnight, our thought process was, why not secure the airway with a tracheostomy, which you can remove in 5 to 7 days. So that's why we had a higher rate of tracheostomy subsequently. But once we started with ligation of facial artery and lingual artery in all our cases, and doing meticulous ligations and clipping intraoperatively, intraorally as well, we started extubating these patients on table, and our tracheostomy rates have come down.
One of the questions on the chat box was also whether the rate of hemorrhage is higher if you do a staged neck dissection or you're doing a simultaneous neck dissection. Any thoughts on that?
So most of our patients undergo simultaneous neck dissection. I have no experience with staged neck dissections, but whatever previous literature I have reviewed, they say there is no difference in rates of hemorrhage if you are clipping, selectively clipping the facial and the linguals simultaneously as well.
What about Dr. Paleri has a point to make. I see you've raised your hand.
Yes, it's more of a question to Uma. I don't know if he has some inside knowledge. So with Orator 2's protocol, they clearly want a 1 centimeter margin around the tumor. And I don't use a 1 centimeter margin when taking out a T1, T2 tonsil tumor, not even for recurrences. So if you take a standard tongue base and you take a 1 centimeter margin, it's right across the midline in those instances. I wonder if that's why the bleeds and these things happened. It could be the contralateral dorsal lingual, I'm saying. If that's exposed relatively easily. You don't tie the opposite lingual off, then this must have, I'm just speculating here.
Yeah, something about this entire process doesn't make sense to me. I was very, very happy to hear from Dr. Ghosh that this trial is not being interpreted as a death knell for TORS, because I think it is not appropriate to do that on the basis of this particular trial in this particular instance. I mean, as you said, Vin, very eloquently, they didn't really meet the endpoint or safety endpoint. 5% safety endpoint was not reached. So why did they terminate so quickly? Maybe they realized that 1 centimeter is too big of a margin. I don't think anybody is taking 1 centimeter on any of the other prospective trials, whether it's surgical or not. So there's a lot of parts of this that don't make sense, but I do think that the bigger you go, the wider you go, the more likely you are to have contralateral disease, the contralateral vessels exposed, and then you risk having some bad complications because clearly we cannot ligate both lingual arteries on these patients. That defeats the point.
So I think with respect to postoperative hemorrhage, take-home points for the students are that you should preferably ligate the facial and the lingual vessels when you're doing base tongue or tonsillar resections. Put in the tonsillar bed, also put a lot of clips. If you suspect that your airway is compromised or you may have a problem, I think it's safer to do a tracheostomy. And I know that though our threshold is much lower to do tracheostomy, maybe compared to other centers, it may be a safer place to be in, especially if you don't have that kind of volume of disease. We are already at 9:05 and we are late. So I'm going to quickly skip to the thyroidectomies. And I personally do not have experience of doing robotic thyroidectomies. So I want to bring this case across. Now, this is a 25-year-old young girl who has incidentally detected thyroid nodule, which is sub-centimeter. The Bethesda, it's Bethesda 5, that's suspicious for malignancy. And based on all imaging and information which was available to me, this is a case shared by someone else. This patient is a stage 1 cancer because extremely low risk. So would you all offer a robotic thyroid for this patient? Let's start with, Rajeev would. What about you, KK?
Rajeev is taking?
Rajeev will. Yes, Rajeev, go ahead.
Hello. Hi, yeah, this patient, this will be a simple hemithyroidectomy robotic. Either it can be retroauricular approach or it can be transoral approach. So retroauricular will be quite easy in this case because very small lesions. So my preference will be retroauricular.
So you would offer a patient the robotic surgery for this patient. What about you, KK? Would you upfront offer the patient or only if the patient asks for it?
Yeah, nowadays we are offering for young females.
Okay.
Yeah, and mostly this patient will go for a robotic hemithyroidectomy, a retroauricular approach.
What about our colleagues from overseas? Dr. Paleri, Dr. Uma, would you offer the patients upfront robotic thyroid surgery, or that's a patient's choice if they ask you for it?
I don't have a robotic thyroid practice.
Okay.
So
4 centimeters front to the neck, it's out. Half an hour later, 45 minutes later, it's out.
Yeah, so I agree. I think that this is one of those operations where we have to be very careful that we understand why we're offering it and why we're doing it and what the goals of this operation are. Really, it's to avoid a scar. There's no data that demonstrates that this operation, or this approach, I should say, is a different operation or has any really significant benefit over standard thyroidectomy. So I tell the patients that. But for young women, especially, I recently did one on a 15-year-old girl who had a very similar sort of story. And she was very concerned about having a scar, as was her mother. And so I offered it. So I offer it to people, but I tell them very bluntly, this is an operation that takes twice as long, is not necessarily better for you, but the only reason we're doing it is to avoid a scar. But I do inform them that it is a possibility.
I think the scar is the only issue for which you can really offer a robotic thyroidectomy. Now, the surgeons, KK, Rajeev, and Uma, what is your preference for the approach? Would you do a retroauricular or do you do an axillary? Or does that also depend on what the patient wants?
For me, it's always retroauricular because that's what I got trained in. But there are people who do, BABA approach and all those things for total thyroidectomy. But depending on the training, and if you're trained in all, you could do that.
What about you, Rajeev?
I discuss all the transaxillary as well as now transoral also I have started doing. So most of the patients, they opt for retroauricular. Till now, no one has opted for transoral or transaxillary. I don't know why, but they are more comfortable with retroauricular. So all the patients, I give options of open versus robot-assisted hemithyroidectomy. And depending upon their choice, only we do. But all these patients, young patients, we offered both the approaches, open versus robot assisted, and that is up to patient choice to decide.
Listen, Deepa, I must make a comment. Rajeev, I can't resist making this
I was going to ask you to hold on, sir, but
No. I have to respond to Rajeev. He said that patients opt for retroauricular, and I don't know why over transoral or the axillary approach. I want to tell you all, and I've seen many a summer more than all y'all guys. It depends how you talk to the patient. You are sold on retroauricular, and that's why they agree. I mean, if it's someone who's very compelling, they'll even sell a transrectal approach to a patient. You can sell ice to an Eskimo. It depends how you convince your patients. Rajeev, introspect, if you tell them the other two approaches fairly convincingly like retroauricular, you'll have patients opting for that as well. And it's not only here, it's all over. That's how you counsel a patient.
Okay, sir. Thank you, sir.
So I think let's not get into the SCAR, because I think SCARs are the choice of approach, and the SCAR is really dependent on which country and what the population is. Like Koreans would do anything to avoid scars in the neck, and that's why the transoral approaches and the axillary approaches are much more common in them. But let's talk about what's more important to us as oncologists. When we treat cancer, what are the complication rates, and how do we reduce the complication rates when we do these robotic approaches? We've heard of recurrent laryngeal nerve injury rates. We've talked about hypocalcemia, but no one ever seems to be talking about the external branch of the superior laryngeal nerve, which for this young age group of these will be young females. If they lose the external branch of superior laryngeal nerve, they are going to have really bad pitched, very low pitched voice, which will not be good for them. So how do you take
external laryngeal nerve can be seen by a retroauricular approach. You have to retract laterally the superior pole, and you will be able to visualize it. It's not a problem. Maybe, but in the initial learning curve, it may be difficult, but it can be done.
Dr. Uma, you have something to say?
Yes. Yeah. So I'm a big fan of finding and preserving the external branch of superior laryngeal nerve. We've just completed a prospective trial on this, and we're trying to get it published. It's amazing how few people care about this in the literature and how little is written about this. I think it's unfortunate. I find that in the robotic approach, as KK just said, you can find the external branch if you're looking for it. However, you have to, because of the superior to inferior trajectory of the dissection, as opposed to the open approach in which you're going either from lateral to medial or really en face, identifying and dissecting Joel space becomes a bit more challenging. And so with the robotic approach, I find myself often taking down the superior pole before I see the EBSLN. Whereas in the open approach, I see the EBSLN, I stimulate it, I preserve it, I move it out of the way, then I take the superior pole with ligation. So I think there's going to probably be a higher rate of transitory EBSLN injuries in these patients, but I don't know if that will actually pan out.
Actually, under the robot, the visualization of the superior pole, each vessel and each nerve is very, very clear and crisp. So you can do a better job with robotic.
Let's talk about some hard outcomes. Rajeev, the data from this meta-analysis, which is recent, shows that when you talk about open surgery, the post-operative TG, which is one of the markers of completeness of surgery, is better in the open group compared to the robotic group. What would you say?
I don't think because robot like retroauricular approach, whatever you do in open surgery, same thing can be done with robotic approach. So there is no question of leaving thyroid tissue in case of malignancy. So because a lot of patients I have just I'm following up without giving radioiodine because TG value was less than 1 in these patients. So till now we have not analyzed all our patients because till now I think our number will be around 30 or so. So I have not analyzed and compared with my open thyroidectomy patient. So I can't say about my patient. But overall, whatever procedure, robot-assisted procedure is retroauricular, the clearance is as good as open thyroidectomy.
So I think the problem with all this data for thyroid is it's a lot of, even if it's called a systematic review and meta-analysis, most of the data is from South Korea. A lot of this is non-randomized data, and a lot of the data is very heterogeneous. So they are not really comparable groups. Would you have, what's your take on this, KK?
Yeah, I agree with you. Most of this meta-analysis and all the robotic thyroid data is from South Korea. And we have to understand that total thyroidectomy is the standard procedure. And there would be a lot of learning curve data. I mean, the people starting the robotic career and all those data will be added onto the robotic arm. So definitely those arm will have temporary complications, more complications if you look at it.
So I think I'm at the sort of end of my session. I'm just looking at what are the questions in the chat box. Maybe Harsh, if you can put up a few to the panelists.
Yes, ma'am. I think most of the questions have been dealt with already. I doubt there was a question on margin that I think has been addressed, whether we need to, whether we are going to change margins for the HPV negative tonsil. There was a question about any difference between the axillary and retroauricular approaches in thyroid, but as the panelists have said, it's up to individual preference. So I think I don't see any impending question as of now. I think all the questions have been answered well on the panel.
So as Dr. De Cruz is here, I think he should have the last word. And I think he'll sum up the whole session for us. I thank all my panelists, Dr. Sarbani, K K, Rajeev, Karan, Dr. Paleri, Dr. Duvvuri, and of course, Dr. De Cruz. Thank you so much, and over to you.
Deepa, great panel. I think you made my job very easy. I actually want a show of hands whether they really want me to make some comments. But I enjoyed all 4 presentations, great talks. And like I said in the chat box, I just hope more youngsters were on this. I mean, it was an absolute treat. Vin was superb as usual, gave some great insightful points, dissected everything very well. Uma was also very good, telling us the future. And I think both our home batsmen did outstandingly well. KK, congratulations on your effort of developing robotic thyroid in the country. And Karan, you and Surendra, congratulations for pushing the boundaries on robotic oropharyngeal surgery. Harsh, congratulations to you and the leadership for a great session put together. I only, if I had to criticize one comment, I would say I hope you had given a talk to a radiation oncologist to give you the other side, because we surgeons always show some good results with us. There's a lot moving in radiation oncology. There are a lot of new developments, and probably that would have balanced a bit. But I think Sarbani did make some mindful comments. Now, quickly, I'm not going to be very long. The aim of any cancer is to control with minimal morbidity. And I think this paradigm, and I'm only focusing now on oropharynx, is most important when you come to the HPV cancer. And that's because these patients are younger and they live longer. And you don't want to have chronic side effects of dysphagia coming 5 and 10 years later in a cured patient. So mark my first word, it's important paradigm in HPV, and that's the reason why robot came into the HPV story as a treatment. So basically, when we are looking at the best treatment, you look at two endpoints, survival and functional outcomes. Now, survival will be more or less similar in all studies. It's something like END versus a sentinel node biopsy. You can have 10,000 patients, survival will hardly move. It all boils down to functional outcomes. As of now, data is not robust to show you're improving outcomes if you gave surgery followed by radiotherapy. Now, let's first look at radiotherapy, and Karan put up McCarthy's paper. I think that one paper did a lot of disrespect to the radiation oncologist. It was an honest assessment. It was in the early 2000s. But historically, in all those trials, it was 2D CRT. The needle is moved. We've now got 3D CRT. We've got IMRT. We've come to DAS, that is dysphagia-associated related structure saving. And today, the current status is should be IMRT with VMAT. And I think when you look at that, then you'll have a true idea of the complications. Look at Chris Nutting's passport study, IMRT versus 3D CRT. The xerostomia fell from 74 to 38%. So if you did the 3D CRT data, you would have more complications of xerostomia. So techniques are changing. Also, what we have realized is that volume and dose both play an important role in side effects after radiotherapy. 53 is better than 63. That's the dose. And you can save volumes. Now, you heard all our panelists time and again struggling and telling us that 1 millimeter, 2 millimeter, 3 millimeter margins. So maybe the radiation oncologists also need to compromise or cut down on the volumes that they treat. And Isbrooks does doing lesser margins, saving the supraglottis, avoiding radiating the retropharynx, saving the constrictors may cut down the side effects of these radiotherapy. TAWS functional outcomes are best if you do surgery as a single modality. Look at the Orator, and I already said this, 10 out of 34 was single modality, 24 out of 34 needed some subsequent treatment. So try to do your selection for TAWS in patients who need single modality, and I wouldn't fight it, those kind of cases. That's exactly as we would treat oral cancers, where you can get out with a quick surgery as opposed to long radiotherapy. Now, TAWS, and I made this point in the panel, is technique related and it has a lot of costs. And when you look at publication, there are publication, but it's usually from the same suspects. You know, the same guys publish on oropharynx. And I think we need to have more people adapt this for this to come to standard of care. It was exactly the same with laser. Look at free flaps in comparison. There's just an overwhelming evidence in favor of free flaps. Everybody learned that technique, but laser still flounders, and it's been there for 20, 30 years. And I suspect the same is going to be happening for radiotherapy. Look at Tata's, which is the Mecca. I think the number of robotic cases will be less than a handful, at least when I was there, unless the guys have changed. There's hardly anything. You don't see the ideal case. So in the absence of RCTs, and I'm not undermining TAWS, do TAWS, but do it in a protocol setting, do it in prospective cohorts. Remember that this is proven for HPV positive. So if Karan's doing it, he's capturing the data well, and we learn with time. And remember to choose all this when you have a single modality. Otherwise, CTRT is the standard of care, unless you're an expert in TAWS and your center does it very, very well. De-escalating is not standard of care as of now. And the cetuximab story is out. It does not rule out de-escalating, but maybe the approach of a targeted therapy was not the right approach. That means cetuximab, it came in after Bonner's study and post-hoc analysis. Maybe that's not the right way to go. Downstaging the dosage, downstaging the volume, giving risk-stratified adjuvant treatment may be the way to go. So in conclusion, robot only if you're an expert capturing data, adding to literature, and as more data comes, we will evolve our guidelines and adapt it into standard of care. 2-3 quick lines on thyroid. Remember why thyroid robotic came in South Korea. $400 to screen for 5 cancers below the clavicle, added $25, they put an ultrasound probe on the neck. They got more than 80% of their cancers, which are less than 1. New England Journal publication. 25% had complications. Any of you all have been to Korea? You'll see boo shops and you'll see beauty product shops. So imagine if you, at the airport, imagine if you told a young or a Korean woman that you've got a less than 1 centimeter nodule and you're going to get a scar in front of your neck. They're not going to agree. That's how the robot came. So out of 20 publications, when I last read the literature, 17 were from Korea, only 3 from the West. They also have favorable anthropometry and also the culture of wanting, you know, I would say they're vain. They just don't want that scar there. So there's level 2 evidence to tell us that there's safety, feasibility, and equivalence of the robot in thyroid. The only thing where the robot scores over conventional surgery is scar and pain. Balance it with high cost, operative time, unusual complications like brachial plexus injury, and the learning curve. Remember one thing in thyroid, I do a whole lot of thyroids. Thyroid is directly proportional to the volume that you do. And there's enough data for open. You do more than 25 a year, you'll be better. Now, if you all guys are doing less than 35, what did KK tell you? He struggled. He showed you some figures, 25, 30, 35. Don't please dabble with robotic thyroid unless you're an expert. So to conclude, if I had a patient, a film actress who came to me and said, I don't want a scar, I won't do the robotic thyroid. I'd either fly in KK into my center or send the patient to KK. I think I'll do the former because KK said he offers it to young women and I don't want all of them to be in Kerala. I want some to remain in Bombay with us. So KK will fly in. But the point I'm making is, please do it if you are of KK skills and you've done enough. Otherwise, don't dabble with that occasional case on robot. Unless you're learning and you've got someone to mentor you. So in brief, these are my comments. And thanks once again, guys, for having me on. And a great show from everybody who participated today.
Thank you, sir.
So thank you so much for those wonderful comments. Really thoughtful and insightful. And you summed up the entire evening's discussion really, really well. I would take this opportunity to thank all the speakers, Dr. Vinidh, Dr. Duvvuri, Dr. Thankappan sir, Dr. Karan, Deepa ma'am, Rajeev, Sharan sir, everyone and all the listeners over here. It's quite late in the day and we still have more than 50 people on the panel, which is really, really great. Thank you all. And I would take this opportunity to thank the NH management, Dr. Rupert, Dr. Poorna Kurkure ma'am of the Collegium, and of course our chairman, Dr. Devi Shetty, for encouraging these talks. With this, we would want to end here, wishing everybody a very safe and healthy time in these difficult COVID times. Thank you all.